this. So basically the therapy of this condition, the trials and all research, if we just date back, it started from 1960s. So at the initial part, there were empirical treatment, mostly vasodilators were used. Then in 1980s, oral anticoagulants was found to be very, very effective. And now till date also, this has become a standard of care in this condition. All majority of the patients are actually receiving some form of oral anticoagulant. Then in 1995, the prostacyclin era started, initially IV epoprostenol, then in 2001, Bosentan, 2002, treprostinil, which emerged as a subcutaneous therapy, followed by IV treprostinil, iloprost, later on inhalational iloprost, and sildenafil. It was available in 2005, 2007, ambrisentan, then 2009. Tadalafil, another phosphodiesterase inhibitor, and treprostinil now it was available in inhalational form, 2010. Thermostable form of epoprostenol, a prostacyclin derivative was available. Then Rayoshiogart, the initial trial was very encouraging. I'll briefly show that trial, 2013, and macitentan and treprostinil oral. So first time oral prostacyclin derivative was available, 2013. And the latest established therapy in this particular situation is Selexipag, which was available 2015. So these are the different classes of drug which are available for treatment, mostly the prostacyclin derivative, initially IV infusion followed by inhalation, iloprost, treprostinil is available in all the form, oral, inhalation and subcutaneous as well as IV. Prostacyclin receptor agonist, the latest development, Selexipag, oral. It is supposed to be started at a dose of 200 microgram twice daily, and gradually we try to build up the dose up to 1600 microgram per day. And then there are endothelin receptor antagonists in the form of bosentan, ambrisentan, macitentan. All of them are oral. Bosentan had important limitation in the form of hepatotoxicity, which was taken care of by the further generation endothelin receptor antagonist. Phosphodiesterase 5 inhibitor, probably the cheapest one to treat this condition. Sildenafil, widely available. Tadalafil, little costlier, but yes, it is also widely available, and we use them very often. And both of them are available oral, and sildenafil IV injection is also available. Soluble cyclic GMP stimulator, Rayoshiogart, was evaluated and found to be very effective, and so oral formulation. So if you look at the timeline of the different studies and trials, so initially all the trials, say for example the trial with Bosentan, Breathe 1, and ambrisentan, ARIS 1, ARIS 2, all of them actually were shorter studies. Basically they tried to improve the quality of life of the patient, to improve the 6-minute walking distance, and those were the primary outcome. And short duration studies were actually performed. Gradually, initially the studies used to be 32 patients, 200, 150, this kind of small study and small follow-up. Later on, when we got more important and more effective molecule in the form of macitentan, first time in Seraphine trial, it included 742 patients, and we can see the primary endpoint also changed. The trials become larger, longer study period, and basically event-driven outcomes. So they tried to look whether the survival benefit is there with the newer molecule. There had been the largest trial in this situation was with Selexipag in the form of Griffon trial, which included more than 1,000 patients was evaluated. Then the era of combination therapy, the first landmark trial was Ambition trial, which combined ambrisentan with tadalafil. That was also relatively a larger study with longer follow-up period, and it was also an event-driven trial. So what it indicates that probably we are getting more effective molecule for treatment of this very, very lethal and fatal disease. Now coming to the important adverse event. Now we all know endothelin receptor antagonist fluid retention is important adverse effect. Anemia and abnormal LFT with Bosentan, which is well known. They are not tested in pregnant ladies, Phosphodiesterase inhibitor, headache is important, nasal congestion and GERD, which is not a very important side effect, prostanoids, headache, and very typical side effects of jaw pain and bone pain, particularly if you're using intravenous formulation. Flushing can also be there, and line infection and cough if you're using inhaled form or injectable form. Those are additional adverse effects because they need to take it for a longer period of time. They might be discharged home and they are taking it at home. So this side effects becomes important. Now, soluble guanylate cyclase ricin can cause headache, symptomatic hypotension, syncope, dyspepsia, some peripheral edema, and they're also not tried in pregnant ladies. Now, if we look at the flow chart, how we should try to treat the algorithm, then World Symposium of Pulmonary Hypertension 2018 is the latest guideline, and first thing we should do to treat this kind of patient is to check the vasoreactivity, whether the pulmonary arterial hypertension is vasoreactive. If it is vasoreactive, then yes, most important treatment is calcium channel blocker, but the dose of calcium channel blocker which is supposed to be given many a time is not tolerated by the patient, but if they tolerate, then it works very fantastically. Now, if it is not vasoreactive, then we need to assess whether the patient is having low risk, intermediate risk, and high risk, because this is very important. Say, for example, a patient who is having right ventricular dysfunction, which is not responding with diuretic therapy, and the functional class of the patient is very advanced, then this is a patient who is actually very high risk patient, and we should initiate combination therapy from the very beginning, including injectable formulation of prostacyclin. Otherwise, in some of the patients, probably we can try monotherapy. So monotherapy is not altogether obsolete, though the fashion nowadays is to start combination therapy from the very beginning, either double drug. I'll show you some trials with triple drug combination from the very beginning as well. So there are group of patients who can respond with monotherapy, say for example long-term stable patient, say, or in group of patients where combination therapy is unavailable or contraindicated, those kind of patients. And there are some other conditions where monotherapy can actually be tried. Now, there is something called worsening pulmonary arterial hypertension and disease progression. So any patient, when treated with the initial therapy, if he doesn't respond or he progresses to the next functional class, then we'll consider the treatment to be failure, and we should try to add on modern therapy or other, next stage therapy. Say, for example, lung transplantation, balloon atrial septostomy, and hospitalization and in-hospital treatment, intravenous treatment, those kind of situation actually arises. Now, basically, my job is to discuss about the newer discoveries and newer avenues in this very deadly situation. So one of the new research actually is concentrated in the field of metabolic basis of pulmonary arterial hypertension. So just I'll quickly touch upon the insight from the NHLBI pulmonary vascular disease phenomics, which is also commonly known as PV-domics study. So this is a worldwide network where actually different phenotypes of the disease, idiopathic pulmonary arterial hypertension, actually are being analyzed. And why they're doing so? Because the global metabolite group comparison, they actually try to evaluate different protein, nucleotide, and lipid, and they actually classify the patient in different clusters, and these clusters may not be similar to the WHO or World Symposium of Pulmonary Arterial Hypertension cluster. There are 30 top-ranking biochemicals in the importance plot suggested by key differences. So they analyze the amino acid metabolism, lipid metabolism, nucleotide metabolism, and by that different parameters after analysis, they differentiate the patient into different clusters from cluster 1 to cluster 6. They also take consideration important clinical marker in the form of distance walk from 6 meter walking test, DLCO, RA pressure, mean pulmonary arterial pressure, cardiac output, cardiac index, and PCWP. And why they are doing it? Because this PV-domics, they uses deep clinical and panomic phenotyping to identify novel subphenotypes of pulmonary vascular disease, regardless of the World Symposium of Pulmonary Hypertension clinical classification. And preliminary metabolic data from this actually reveals that novel metabolic amino acid and lipid cluster that are not defined by the existing group or hemodynamics are there, and they can actually get benefit by targeted therapy of different kinds. So regarding the management, what is new? Yes, there has been correlation between gut pathology and its rescue by angiotensin converting E2 enzyme in hypoxia-induced pulmonary hypertension. So it was found that there has been a link in between ACE2 overexpression for this, hypoxia, which is there in gut, and this in future can be one of the target for therapy of this condition. So that is also important. Upfront combination therapy, I already mentioned that from the very beginning, in very high risk group of patients, combining 2 molecule or 3 molecule from the very beginning is showing very encouraging data. And upfront triple therapy has been evaluated. It started way back in 2014, initial trial. Data shows that if we combine the recovery of the RV function is far better compared to single therapy or combination with 2 therapy. And so this kind of effort is continuing. They're actually trying to find out what are the molecules which we should combine from the very beginning, and they are actually analyzing data. This is one of another trial where ambition plus subcutaneous treprostinil, that means ambrisentan plus tadalafil plus subcutaneous treprostinil was used in very sick patient, class 4 symptomatic patient or class 3 very high risk feature patients. And what was the result? Result was actually very encouraging. All the parameters were statistically found to be better, starting from right atrial pressure, mean pulmonary arterial pressure, and the functional class of the patient actually improved in this 24-month follow-up. But the problem is all these trials are very small size trial. We cannot conclude that we should offer this combination, triple or double combination to all the patients. But so far, whatever data we are having in very sick patient, particularly high risk patient, if we combine multiple therapy, the benefit is evident. This is another very recent data. 2020 publication of Triton triple therapy, 247 patients, and this found that combining triple therapy in a very sick patient actually is far superior compared to the single therapy or combination 2 therapy. Now, what is the consensus regarding this multi-pronged approach from the very beginning? ACC/AHA guideline recommend that intravenous or subcutaneous treprostinil as second or third line therapy in patients that are considered low risk, while IV eprostenol and treprostinil are considered first line in high risk. So if the patient is high risk, we should go for injectable form, multiple medication from the very beginning. Similarly, 2015 ESC guideline and 2019 World Symposium on Pulmonary Arterial Hypertension gives similar recommendation that IV prostacyclin should be initial therapy in WHO Group 1 functional class 4 patients only. So that is the consensus. Now, another very important molecule, new molecule I'd rather say, is the sotatercept for the treatment of this condition. This actually bone mineral protein, there is a disbalance in the growth promoting and growth inhibitory mechanism, and what this molecule does, it actually restores this derangement, and this is a very novel treatment. The trial came up in the name of Pulsar trial, and this showed that both the doses, this is available in subcutaneous form, 0.3 milligram per kg and 0.7 milligram per kg, and the result, the Pulsar trial showed that, this is a very important trial, showed both the doses actually is statistically superior compared to conventional background therapy. So all the patients were optimally treated as per the current guideline. On top of that, this new molecule showed benefit. Now, replace study I already mentioned. This is the study where this molecule Rasiagat was tried. So one group continued with phosphodiesterase inhibitor. Another group, the phosphodiesterase inhibitor was replaced with this new molecule. And what was found, endpoint, patients where in primary endpoint were met was far superior in the ICR-GART group, and it was statistically significant with a p-value of 0.0007. So this molecule also probably opening a very new avenue, and this is available oral. So this can be a very important therapy in this particular condition. Now, inhaled treprostinil in this particular situation has also arisen, and the trial with inhaled treprostinil was also found to improve the functional as well as the hard endpoint of the patient. Now, another very important, new avenue of treating this condition is the pulmonary artery denervation. Dr. P.K. Hajra might be interested. So the denervation is, shifting base from renal artery to pulmonary artery. So the patient who actually undergone pulmonary thromboendarterectomy, this group of patient was chosen, and one of the arm, the conventional oral therapy and IV therapy was continued. Another arm, they subjected the patient with denervation therapy, and what was found, the denervation, we can see the gap in between the clear separation. So pulmonary artery denervation is another very new novel therapy which is probably coming in a big way. Initial trial result is very promising. It reduced the pulmonary vascular resistance in a significant way. So other trials to note is
please conclude.
This is probably my last slide, sir. Co-op trial that evaluated transcatheter mitral valve repair, that also showed by curing mitral regurgitation, probably PA pressure can be improved. And I think I should stop here. This is the last slide. Yes. So we need to find out the COVID-19 related pulmonary arterial hypertension, how they behave. I think I should stop. Thank you, sir.
Brilliant. I would say a brilliant talk by Dr. Pandey. Exceptional talk, class 1 talk. Now, I think the story is still evolving over time, and you ended up with COVID-19, and some of these patients do need lung transplantations, and it is possible in our country. The first line of therapy in any pulmonary hypertension, you have to rule out secondary causes, and you have to give continuous oxygen therapy, ambulatory therapy, which is available, affordable, and attractive, and sometimes a combination. And he has highlighted the pneumotherapy, a device therapy. Only one thing he has not mentioned, and I do have some cases of pulmonary angioplasty. You have to do the CT angio, then you have to do the FFR of the pulmonary artery, smaller branches, and you have to treat them by balloon angioplasty, not by stent. Sequentially, the segmental and subsegmental branches of the pulmonary artery. Sometimes the combinations. Be aware of the side effects like hypotension. Another therapy in the field of diabetes, like SGLT2 inhibitors, are quite promising in the treatment of pulmonary hypertension. But he has exposed a new horizon, a new kind of polypharmacy in pulmonary hypertension. Thank you very much, and over to Dr. Guho and Dr. Shoji.
Thank you, Arindam. That was a very lucid lecture, though there's a lot of information, and you don't really have a take-home from that. Now, one question I want to ask you, in patients with Eisenmenger, so that is the commonest problem that we face. So what is the drug of choice in such cases? What is the drug of choice to treat the pulmonary hypertension?
That drug of choice, I mentioned that treatment of choice is heart-lung transplantation. You also know that, Eisenmenger. If you really want to cure the disease, you need to transplant both heart as well as lung, because the vasculature, there is obliterative pulmonary arterial hypertension. But apart from that, now all the studies are indicating that whatever therapy we are offering to idiopathic pulmonary arterial hypertension, we should offer them to this Eisenmenger syndrome patient, and they actually benefit. They benefit, and we should offer all the available. As per the functional class, we should see what class the patient is. If they are at a higher class, say for example, very sick class 3 or class 4 patient, WHO, we should start with IV or oral prostacyclin derivative, along with the other conventional therapy in the form of ambrisentan, bosentan, whatever, and phosphodiesterase inhibitor. And also we do have selexipag nowadays. Selexipag is available, is marketed by some company in India as well. We should offer. All of them can be offered to this group of patients.
Yes. Showed up there. Just
Hello?
conclude.
Can I ask
so I think,
Kajal, 1 minute.
Can I ask?
Yes,
sure. One question.
Sure. Yes. Arindam, UCD cannot be used with phosphodiesterase inhibitor.
Yes,
so
that has to be.
first line drug. That is the ERA plus
Don't share the screen now. I will tell you.
Plus Riociguat.
Yes, sir. As you got the replace trial clearly shown, you need to stop. And one of the arm they continued with phosphodiesterase inhibitor, and the arm where the Riociguat was evaluated, the phosphodiesterase has to be discontinued, because if they are used together, there can be potential risk of serious hypotension.
Right.
Serious hypotension.
Exactly.
So
Very
it should not
serious hypotension does take place. So these two should not be used together.
Right.
Another thing, what Shodo asked, bosentan is very often used in combination with a phosphodiesterase 5 inhibitors in patients with Eisenmengers. If bosentan is not tolerated, ambrisentan, but you have rightly said that any drug which are used in primary idiopathic hypertension can be used in Eisenmenger syndrome as well.
Right.
I think we are running short of time. Thank you, Arindam. Thank you, Prakash and Shodo. The next session is current management strategies in the treatment of pulmonary embolism. To chair the session, we have Dr. Kajol Ganguly and Dr. Soumitra Ghosh. And to speak on this subject, we have Dr. Dipankar Ghosostira. Dipankar, please start sharing your screen.
And thank you, sir, for having me here. I hope I am audible and my slides are visible.
Yes.
I'm going to talk on current management strategies in the treatment of pulmonary embolism. Case of 41-year-old male with no significant past medical history and who suddenly presents with in the emergency with shortness of breath after a syncopal event. The only remarkable findings on clinical examination are he's hypotensive with a blood pressure around 84/49 and having tachycardia, and the oxygen saturation is around 92%. So these kind of findings and this kind of presentation, you have to think of pulmonary embolism. And it is extremely difficult to diagnose at times. Now, it's basically a clot in the venous circulation which has migrated to the lungs. Now, the most common thing to migrate are thrombus, but apart from it, it could be air, fat, amniotic fluid, or septic embolism or tumor embolism. One must not forget what we learned in our old school days in pathology, the virtuous triad, that circulatory stasis, endothelial injury, and the hypercoagulable state. They conglomerate to form thrombosis, most likely in the venous system, and that leads to formation of pulmonary embolism. So the risk factors are either major trauma, surgery, in which the lower limb fractures, they are paralyzed, the patient is bedridden, different types of cancer, estrogen-containing oral contraceptive pills, having blood transfusion or erythropoiesis stimulating agent, then the temporary pacemaker insertion lines, and finally thrombophilic disorders like factor V mutant mutation, protein C deficiency, or protein S deficiency. And in current scenario, we must not forget COVID infection, which by and large is now the most common cause of pulmonary embolism in our clinics. Now, majority of the patients, they present with dyspnea, chest pain, or pre-syncopal-like symptoms. There is maybe signs of hemodynamic instability in the form of hypertension, shock, or there may be history of cardiac arrest also. 40% of the patients do not have any predisposing factors, and that makes this diagnosis extremely difficult. Hypoxemia is frequent, and hypocapnia may also be present. So there are certain scoring systems in which helps us to diagnose pulmonary embolism, and most of the scoring systems, they include all the risk factors that I have discussed before. So the more the score, the more the probability of having PE. Now, ECG, you may get a sinus tachycardia with RV strain pattern, and S1Q3T3 is also a hallmark of pulmonary embolism. Echo findings are very important, and you get an enlarged right ventricle. In whatever view you see, there is an enlarged right ventricle, and the RV basal movement is compromised with scaring of the apex, which is known as the McConnell sign. And often you get a flattened septum on all features of RV volume overload. And a very important sign is the 60-60 sign, in which the pulmonary acceleration time is less than 60 millisecond, which is suggestive of like in pulmonary hypertension, but the PA pressure never exceeds 60 millimeter of mercury. So the pulmonary artery pressures are elevated, that is more than 30, but less than 60, and the acceleration times are reduced, which is known as the 60-60 sign. You can even detect a mobile right atrial thrombus also, and the TASPE and the systolic tissue Doppler, the systolic excursion of the tricuspid valve, all are reduced in pulmonary embolism. The chest X-ray may show focal oligemia, suggestive of the Westermarck sign. There may be enlarged right descending pulmonary artery, which is known as the Palla sign, and Fleischner sign, which is the dilated main pulmonary artery. And very rarely, you may also get a Hampton's hump, which is a peripheral wedge-shaped opacification lateral to the pleural surface, adjacent to the pleural surface, suggestive of some form of pulmonary infarction or a peripheral pulmonary embolism. Lower limb venous Doppler may reveal the thrombus, but this is again a rare finding. One important test one can do with less radiation is the VQ scan, and there is a defect in the perfusion with normal lung ventilation. So this is again suggestive of pulmonary embolism. But however, nowadays, most common investigation that is done is CT pulmonary angiography. You can straight away go for a CT pulmonary angiography, and it will demonstrate the thrombus in the major vessels or also in the subsegmental vessels. Gold standard always has been pulmonary angiography, but it is difficult to perform because cath labs are not always readily available, or the patient is too unstable to take it up on table. Now, one important point is that both CT pulmonary angiography as well as the pulmonary angiography, they come at a cost of high radiation exposure, which is sometimes maybe detrimental in pregnant patients or in young female patients. So a VQ scan offers the advantage that it can also detect pulmonary embolism with much less radiation. The other tests one can do are the D-dimer measurement. Now the age, limited D-dimer values are coming up. So as you age more than 50, you add 10 microgram to the levels, age into 10 microgram. So that is also there. Now, what has been seen to be most correlated with pulmonary embolism with high mortality is the features of RV dysfunction in the echo and a raised troponin. So these are certain scoring again to show that the pulmonary embolism severity index, or commonly known as the PACE score. Again, the higher the score, the higher the chance of mortality. Bottom line message is that we divide pulmonary embolism patients as low risk, intermediate risk, and high risk. The high risk patient will have hemodynamic instability, and they will have high PACE scores. They will have features of RV dysfunction, and they will have elevated cardiac troponin or the other markers levels. Now, so basically, the high risk patient, they have got massive pulmonary embolism. The thrombus is in the main vessels, so there is a huge thrombus burden. The intermediate ones are the submassive ones, and the mild ones are the minor or the non-massive ones. Now, treatment of massive pulmonary embolism is going for systemic thrombolytic therapy, and that's got a class 1 indication. And one must use unfractionated heparin as the anticoagulation, and then go with the thrombolytic agents. And surgical pulmonary embolectomy has also got a class 1 indication. Now, our job, which is the percutaneous catheter directed treatment, has got a class 2A indication, and I will be talking in detail about these procedures later on. Of course, one must make the patient hemodynamically stable by giving inotropic support in the form of NORAD or robutamine. And some patients might require ECMO, but the prognosis are extremely guarded. Now, the recommendations again, for the other types or the intermediate types of pulmonary embolism is that you go for low molecular weight heparin, that is anticoagulation preferentially by low molecular weight heparin, which is class 1 indication. Also, you can use fondaparinux, and you can also straight away start with the oral anticoagulation in the form of NOAA, which has also got a class 1 indication. Now, one must be careful that when you are using a vitamin K antagonist, as in cases of, say, prosthetic valve with pulmonary embolism, or the patient is receiving vitamin K antagonist for some other reason, then one needs to cover or do an overlapping parenteral anticoagulation when starting with vitamin K antagonist, as in any other case. Now, NOACs are not recommended in patients with severe renal impairment or during pregnancy and lactation, and in patients like who require a lot of high dose anticoagulation, like in APLA or valvular heart disease. In these kind of conditions, NOACs are contraindicated. Now, for submassive, of course, one can, if the low molecular weight heparins fail to improve the patient hemodynamically, then one may go for rescue thrombolytic therapy, which has got a class 1 indication. Now, as an alternative to rescue thrombolytic therapy, surgical embolectomy or catheter-directed treatment can also be taken up, which has got a 2A indication. Now, one does not recommend, and this I should be very clear about it, that one should not do thrombolysis in intermediate group or in mild pulmonary embolism. That's a class 3 indication. So the volume status should also be taken care of, and the inotropic supports, like I discussed before. Now, among the low molecular weight heparins, the most common agents that we use is enoxaparin, and it has got a twice daily dosage. Fondaparinux can also be used, and the dosage varies with the body weight. Among the thrombolytic agent, we commonly use streptokinase. The dosage is 2.5 lakh unit loading dose over 30 minutes, followed by 1 lakh unit over 24 hours. There can also be an accelerated regimen, like using the 1.5 million international units over 2 hours. One can also use the recombinant tissue plasminogen activator or urokinase. So these are the common thrombolytic agents that we use in pulmonary embolism. Regarding IVC filters, they have got a class 2A indication, particularly if we cannot use the thrombolytics or if we cannot anticoagulate the patient. Now, routine use of IVC filters is again not recommended. That's a class 3 indication. Now, so it's very clear how to manage the massive pulmonary embolism. They need hemodynamic support and they need thrombolysis. And it is also very clear how to go about the mild pulmonary embolism. We just use the anticoagulation. So the intermediate ones, they are the difficult ones to choose, how they behave, and the behavior changes also with time. So let us now look at the submassive group and let us see their behavior with thrombolysis. The results are that in long-term results, the results are better with thrombolysis, even in the submassive group, and they reduce mortality, as you can see in these charts. But the flip side is that if you use thrombolytics, even in submassive PA, they are all associated with major bleeds, and there are increased incidence of intracranial hemorrhages. So they tried half-dose lytic agents. Now, half-dose lytic agents had similar efficacy as with full-dose lytic agents, and that's wonderful. But the bleeding complications with half-dose lytics are at par with full-dose lytics. So the bottom line message is that half-dose lytics are not beneficial, and they are no more recommended for use in pulmonary embolism. So it's not safer. That's the clear answer. Half-dose lytics are not safer than full-dose lytics. So if you are to use thrombolytics for pulmonary embolism, you should be using a full-dose thrombolytics. Now, catheter-directed therapy. So there are 4 types of catheter-directed therapy. One is the standard catheter-directed thrombolysis, which we will take the catheter directly to the site of the thrombus, and we will give the thrombolytics locally. One is the ultrasound-assisted catheter-directed thrombolysis. The other is the pharmacomechanical catheter-directed thrombolysis, in which we mechanically disrupt the thrombus and then we inject the thrombolytic locally. And the other is suction, mechanical thrombectomy without using thrombolytics. So these are the 4 main catheter-based therapies in acute pulmonary embolism, which are nowadays used. Now, one is the direct catheter-directed thrombolysis. Now, it has to be a multi-hole catheters, and the infusion and the dosage rate are a lot less. So here you can see we are using only 20% of the systemic thrombolytic dose. So the chance of having bleeding or other complications which we fear with thrombolytics are much less if you are using the thrombolytics at the local site. So that was the common belief of using catheter-directed thrombolysis. But one must be careful that if you do not impinge your catheter inside the thrombus, the thrombolytic agents are likely to go to the perfusion segments of the lung without entering into the thrombus itself. So the message is that you should bury your catheter inside the thrombus, and through the side holes, then you must inject the thrombolytics so they act in the thrombus itself. Now, thrombolytics has shown to decrease pulmonary artery pressure, and there is improvement in the RV-LV ratio, and the major complications are pretty less because we are using a low dose thrombolytics here. Now, the other technique that one uses here is ultrasound facilitated thrombolysis. Now, this is done with using a catheter which takes also an ultrasound wire inside. Now, as we give the ultrasound energy into the thrombus burden, it is seen that the fibrin, they dissipate. And once the fibrin dissipate, there are more receptor sites for action of the thrombolysis. So that was the theory behind the use of ultrasound facilitated thrombolysis. Now, Sunset P was the major trial that tried ultrasound guided thrombolysis using the ultrasound energy. But the results were not much encouraging. As you can see, the trial compared with standard local thrombolysis, catheter-directed thrombolysis, and the results are at par, both in terms of RV-LV ratio reduction. So, and ultrasound-directed therapy is very costly also. So, it does not offer much advantage over catheter-directed thrombolysis. Now, the other directions of using catheter-directed thrombolysis are the mechanical ones, and you finally develop new types of catheters. You develop new types of catheters, which are these kind of catheters are now available, and they have got multiple sites of injecting the thrombolytic agent through various different pores. This is a Bashir endovascular catheter device for pharmacomechanical thrombolysis. So it exposes a lot of surface area in the thrombus itself for the thrombolytic agents to act. So pharmacomechanical thrombolysis is you can use pulse spray or you can use infusion, but one must be careful. There is always chance of distal embolization with this kind of procedure. And there are case reports that initially there was just a settled thrombus in the main pulmonary artery, which was non-occlusive. But trying these kind of procedures, the thrombus has migrated into one of the major pulmonary arteries either side and has caused a massive pulmonary embolism. So that risk is always there of thrombus migration. So the other options are the aspiration of the thrombus, which is called catheter thrombectomy, and you can aspirate this kind of thrombus. And of course, the larger the catheter size or the bore of the catheter, the more the aspirate it will be. So large bore aspiration catheter is now tried, and these are the different aspiration devices. The common ones are the flow retriever, and they show improved mortality. So there are two sizes here being used. One is the 16 size and one is the 24 size. It's no wonder that the 24 size is showing greater reduction in RV systolic pressure and improvement of the cardiac output. So the more the catheter size is there, the bore of the catheter, the better the results. So large bore aspiration catheter is a good procedure. And here is one trial which is looking at catheter-directed thrombolysis vis-a-vis large bore aspiration thrombectomy. And we got similar results in reduction of pulmonary artery pressure, reductions in the heart rate and hemorrhagic complications. But large bore aspiration thrombectomy has got higher procedure-related mortality, mainly from thrombus embolism. And catheter-directed thrombolysis on the other side has shown greater reduction in thrombus burden. So this is one very important trial which shows a slight edge of catheter-directed thrombolysis over large bore aspiration thrombectomy. And of course, if for the surgeons, the surgical embolectomy, if available, that has got class 1 indication, and they are at par with catheter-directed thrombolysis in terms of mortality reduction, incidence of transfusion, but the length of stay in the hospital is higher with surgical procedures than with catheter-directed thrombolysis. So to sum up, here I've got a lot of trials, and I have discussed most of the results of all these trials. Now, EPOS is the ultrasound-guided versus catheter-directed thrombolysis, as in the Sunset trial. So these are the trials. Now, come up to anticoagulation. Now, if we got reversible factors, then only 3 months of anticoagulation is good enough. But in all other cases, full long-term anticoagulation, lifelong, is recommended. Now, one very important trial I should share here is that low-dose anticoagulant like apixaban, rivaroxaban are as good as using high-dose or full-dose rivaroxaban, apixaban. So now the treatment choice, what we are doing or we are suggesting is that for 3 months you give full-dose apixaban or rivaroxaban as the NOAC of choice, and then you, after 3 months is over, you switch to half-dose rivaroxaban or apixaban for long-term use. So this is the flow chart of how one should treat pulmonary thromboembolism nowadays. One should straight away go for a CT pulmonary angio and decide whether you got a submassive or massive thrombolism vis-a-vis a mild thromboembolism, and then act accordingly. So I think I'll stop here, and I thank you again for your time and attention. Thank you, sir.
Thank you, Dr. Ghosh, for your excellent talk. It was really an learning to everybody present over here. But in the current scenario, in this COVID context, so this pulmonary thromboembolism has taken the center stage almost in every situation. We are facing some problem in these patients who are dying of it. So what should be the strategy to deal with this kind of thromboembolism, pulmonary thromboembolism in this COVID scenario? What should be, because everything is a big challenge in this COVID perspective. So what should be your strategies to deal with it regarding management, prevention, and regarding this investigation also? So can you throw some light in this COVID pandemic situation?
The COVID pulmonary embolism, bottom line, is not much different from the pulmonary embolism case that we used to see before. So again, we are again getting these 3 patterns of pulmonary embolism in the COVID itself, because COVID is basically a vasculopathy. The important component of COVID is a vasculopathy, and there is a lot of thrombus burden in the COVID also. So we have come across cases of acute coronary syndrome with pulmonary embolism also in COVID. So the management will be just as I have already discussed in pulmonary embolism. That is, we need to differentiate whether we are having a case of submassive or massive pulmonary embolism or mild pulmonary embolism. Again, one has to decide, but most patients we are tackling with low molecular weight agents, and one must do everything to make the patient hemodynamically stable. So there are a lot of COVID patients who are now on ECMO support or who require ventilatory support. So basically the management remains same, like we discussed, and long-term NOACs are recommended for follow-up. The NOACs of choice are again rivaroxaban and apixaban, because these are the 2 NOACs with which there are a lot of trials in pulmonary thromboembolism.
Recommended.
Right, sir.
Okay. Thank you. Professor Ganguly, would you want to make any comment?
Thank you, Dr. Ghosh, for a beautiful deliberation. So only thing is that the window of this that is thrombolytic therapy is much longer compared to AMI. That is the advantage.
Yes, sir, because here we have a collateral circulation going on. It is not an end artery, because there is a pulmonary circulation as well as a bronchial circulation. So to develop infarct, it takes a lot more time than in the myocardium. So the thrombolysis, rightly, you can do it even up to 14 days. So there are a lot of case reports of you can do thrombolysis at the 7th day or 8th day. So whenever you detect thromboembolism, plan for thrombolysis if there is a massive thromboembolism, massive pulmonary thromboembolism.
Number 2, we have got a special catheter nowadays for this catheter-directed thrombolysis in pulmonary embolism.
Right, sir. We have discussed all those things. There are lot new gadgets are coming up, but in our day-to-day practice in our hospital, the most common thing one can use is the pigtail catheter. If they can take it up to the main pulmonary artery and do some rotation with the pigtail, that can churn up the thrombus, and you can infuse the thrombolytic agents locally also.
Yes.
So that is cheap, and that can serve the purpose of these kind of very costly gadgets, which are also not readily available. And if aspiration catheters are not available, one may use guide cath, a large 7 French or 8 French guide cath. You can easily take it up into the pulmonary artery and aspirate as much as possible.
Right. The next point which I want to highlight is that you have touched most of the points which are essential for the diagnosis. But main thing is the suspicion. When a patient comes, as you have rightly pointed out in first case, suspicion is the first.
There is always confusion with acute coronary syndrome. The presentation is almost similar. Presentation is almost similar. The troponin may be elevated. People may be thinking that patient has got an RVMI, and we may miss altogether. We may miss pulmonary embolism if one fails to detect the subtle signs of pulmonary thromboembolism in the echo, like McConnell sign or the 60-60 sign. And then again, these are not always 100% present also.
Right. Those things come later on. But first thing, you must suspect pulmonary embolism in a susceptible individual who have got high risk for developing pulmonary embolism, like cancer patients, prolonged recumbency, all those points. So, and take immediate action in massive and submassive pulmonary embolism, so that you can revive the patient.
One question is there in the chat box: what to do if the patient is too unstable to shift for CTPA and your suspicion is high?
Right, sir. That is why I stress so much on the echo. I stress so much on the echo. One must have his suspicion on echo itself. So the main confusion is whether you are dealing with RVMI or you are dealing with there is a pulmonary embolism, because both have got RV movement is RV movements or free wall movement is compromised in both the cases. So if there is, as sir said, there are predisposing factors and the high clinical index of suspicion, then you must start treatment with anticoagulation. And once you are sure with the diagnosis, then and then only you should try thrombolytics. And again, the window period is very large. So once you stabilize, you can always shift the patient next day to the for CT pulmonary. There's no hurry.
Thank you, Dipankar. Thank you very much.
Thank you, Dr. Ghosdosida, for this beautiful session. Now it is over to Dr. Professor Goel.
Time is over. So we should move to the next subject. Salvaging the failing heart, heart failure with improved ejection fraction, prognosis and management. To deal with this subject, we have Dr. Shubhra Banerjee, and to chair this session, we have Dr. B.P. Pandey and Dr. S. Ramakrishnan. Dr. Ramakrishnan, you are here?
Good afternoon, sir.
Good afternoon. Shubhra, please.
Okay. Thank you and good afternoon, everyone. It's my pleasure to be invited to give a talk on a new entity, which is heart failure with improved ejection fraction. And I'm going to specially talk about its prognosis and management. Are my slides visible?
Yeah, make it full screen, please.
Yeah, I've made it full screen.
Thank you. Thank you.
Okay, great. Okay, so as you know, in 2016, ESC guidelines classified heart failure into 3 groups depending upon the ejection fraction. And so these 3 groups are heart failure with the reduced ejection fraction, those with preserved ejection fraction, and those with mid-range ejection fraction, which is now renamed as mildly reduced ejection fraction. However, this year they introduced a new term, which is heart failure with improved ejection fraction. And the reason for this was, it was soon realized that those patients with heart failure with reduced ejection fraction who with treatment improved their ejection fraction, maybe to as high as more than 50%, still they differed in characteristics from those with heart failure with preserved ejection fraction. So it's not just the ejection fraction, it could be something else as well. And to classify patients as heart failure with improved ejection fraction, there must be a previously documented ejection fraction, which is 40% or less. And now the ejection fraction must be more than 40%. And not only that, there has to be a jump of 10 point or more from the previous one. So in other words, if the ejection fraction was 37 and it has now improved to 44%, technically it is not heart failure with improved ejection fraction. Now, this is a new concept, and As you know that heart failure, well, this is why a separate class again, because heart failure with improved ejection fraction was found to have a more favorable clinical biomarker and functional characteristics compared to those with reduced and preserved ejection fraction, but less favorable compared to those in the normal population. In other words, those who never had heart failure. Then the improvement in ejection fraction could be partial, like 40 to 50%, or could be a complete normalization of ejection fraction, more than 50%. Recovery usually happens due to guideline-directed medical therapy or device therapy, but sometimes may also happen spontaneously. But what is most interesting is a significant proportion of these patients with recovered ejection fraction may develop a recurrence of LV dysfunction or relapse, resulting in recurrence of heart failure events. Now, this heart failure with mid-range ejection fraction are heterogeneous. As you understand, they could represent those patients with a reduced ejection fraction where the ejection fraction is improved to that range, or it could equally be those patients with preserved ejection fraction whose ejection fraction has deteriorated. So to classify patients with heart failure with improved ejection fraction, the LV ejection fraction evolutionary trajectory is very important. Otherwise, we can't say whether it's improved or declined or it's just the same. The improvement usually represents a myocardial remission rather than a true cure of heart failure. And the term improved is used rather than recovered because A, it has been seen that despite normalization of LV ejection fraction, these patients may continue to have heart failure signs and abnormal biomarkers of functional impairment. And B, it's seen that the underlying structural cardiomyopathic process may not improve. And there are 10 to 40% of patients with heart failure with reduced ejection fraction may come to be heart failure with improved ejection fraction. However, there's still lack of consensus regarding the treatment. Now, this is what I have already discussed. So heart failure with the reduced ejection fraction may improve to full recovery, more than 50%, or partial recovery, 40 to 50, or there may be no significant recovery. However, even in those where it has recovered more than 40 to more than 50%, or between 40 to 50%, the clinical characteristics, they differ from that of heart failure with preserved or mid-range ejection fraction. Now, let's move on to the prognosis. The CHOP registry has shown that those with reduced ejection fraction, those with improved ejection fraction have a survival which is better than that of reduced and preserved ejection fraction, and also they have less heart failure hospitalization. Moreover, those patients where the ejection fraction has improved to a greater degree have better survival than those whose ejection fraction is improved by a lesser amount. And this was also true for heart failure hospitalization. Now, the Penn heart failure study has shown that these patients with improved ejection fraction have an NT-proBNP value, which is on average less than that observed in patients with reduced and preserved ejection fraction. And the combined endpoint of death, transplant, or VAD replacement was significantly reduced in those with improved ejection fraction compared to the other two. And these findings have been confirmed by a post-hoc analysis of the Valsartan heart failure trial. But what was most interesting is that this slide, this showed that patients with reduced ejection fraction who have actually improved the ejection fraction to the mid-range values, that has been 41 to 49%. And if you compare them with those patients who have been diagnosed as mid-range ejection fraction, but their ejection fraction has not improved, if you compare these two, then the survival is better, a lot better than those who have a heart failure, who are in heart failure with mid-range ejection fraction, but the ejection fraction has remained static. And this is to say, like, if you move forward, you are going to live. And if you are static, then you may die. This is just to add a bit of, something to the story. Anyway, so what are the predictors of heart failure? What are the predictors of recovery in patients with heart failure with reduced ejection fraction? So these are clinical, could be divided as clinical parameters, biomarkers, imaging, and genetic factors. Clinical factors would include female sex, younger age, non-ischemic etiology, shorter duration of heart failure, lower heart failure NYHA functional class, fewer comorbidities, absence of left bundle branch block, and continuation of guideline-directed therapy for heart failure. So if these are present, there's a higher chance of recovery. Patients who have lower levels of natriuretic peptides, troponin, ST2, and galactose-3, they also have higher chances of recovery. Similarly, those patients who present with lower ejection fraction at the initial evaluation have higher chances of recovery. And if on CMRI there is absence of your late gadolinium enhancement, that also indicates higher chances of recovery. Coming to the genetic factors, presence of truncating mutations in the TTNA gene, and absence of activating mutations in the angiotensin converting enzymes or beta-1 adrenergic receptor genes, or absence of pathogenic mutations in some of these locations could also indicate higher likelihood of recovery. Now, it's been seen that 40% of patients with heart failure with improved ejection fraction experience a subsequent decline in ejection fraction. Now, why does a relapse happen? The exact biological explanation is still not known. However, the postulation is the reverse LV remodeling represents a transition to a new, less pathological steady state that allows the heart to maintain LV pump under normal conditions. The reverse remodel heart, however, retains many of the molecular features of the failing heart and therefore is more prone to redevelop LV function in response to hemodynamic neurohormonal or environmental stress. And this article published way back in 2005 actually says that morphological or functional myocardial improvement may occur without widespread normalization of pathological transcriptional patterns. So the real reason may lie in the genes. Now, how to manage such patients with improved ejection fraction? I'll divide into 4 headings. First is whether to discontinue or reduce medical therapy. Secondly, what about CRT and ICDs when the end of life is approached, and whether we need to rechange them or not, reimplant them, and what should be the follow-up protocol. Now, TREAD heart failure is the only study which has looked into this, whether withdrawal or withdrawal of treatment or reduction of treatment would be is feasible in patients with asymptomatic DCM who have improved ejection fraction. And as you see, the results show that there is a significant increase in cardiovascular events in those patients where the treatment was discontinued. So heart failure treatment should continue indefinitely. Now, there may be some exceptions to this. For example, those who present with peripartum cardiomyopathy or fulminant myocarditis or Takotsubo cardiomyopathy, some of them may actually experience normalization of left ventricular ejection fraction. And so in such cases, reduction or withdrawal of therapy may be considered. Now, this shows that in patients with heart failure with improved ejection fraction, beta blockers, but not RAS or MRAs, were associated with a reduced all-cause mortality risk. This sounds very interesting. However, this is the only study, and I think we need to have more data to say that in heart failure with improved ejection fraction, beta blocker is the one that is most necessary. Now, what about Crt generator change? As a rule, Crt should be maintained because, in fact, replaced because electrical dysynchrony and forward LV remodeling are known to recur with loss of desynchronization. But the issue of ICD replacement is still uncertain. We know that improvement in ejection fraction is associated with lower arrhythmic events. However, some arrhythmic risk remains despite improvement of ejection fraction. And because fatal arrhythmias may occur despite normalization of ejection fraction, continuation of ICD has been recommended independent of EF in patients who have genetic mutations such as LMNA, SCN5A, and FLNC. But what about those who do not have genetic mutations or where we do not have genetic study, because it's not widely available? What to do with them? And that's a very practical question. Now, this publication in JAMA, it shows that patients who had an improvement in ejection fraction to more than 35% during follow-up had a similar mortality benefit with ICD as those whose ejection fraction remained less than 35%. So if we consider this, then possibly it's best to change the ICD as well, and when the ERI approaches. Now, the American College of Cardiology has given a statement regarding this, but it's a bit ambiguous. They said that if the ejection fraction has improved to more than 50%, then ICD replacement may still be appropriate, and that although continuation of CRT therapy in patients with prolonged QRS duration is appropriate, replacement of CRT with CRT may also be appropriate. So ultimately, I think it's up to the operator to decide what they are going to do. Now, this is just how to follow up patients who have heart failure with improved ejection fraction. They have to be followed up closely. Now, in all clinical follow-ups, we have to look at take the history, do a meticulous clinical examination and an ECG and NT-proBNP, and then maybe at times an echocardiography, and maybe even less often a CMR if it's available, to look at the function of the heart and some more sophisticated parameters like your longitudinal global shortening. But the patients who are not at high risk, for example, those without persistent left bundle branch block, genetic DCM or high biomarker profiles or more comorbidities, they may be selected. They may be called for review for after a longer period of follow-up. So that is something the clinician would decide when to call the patient. So in summary, knowledge of LVF trajectory is necessary to diagnose heart failure with improved ejection fraction. Recovery usually happens due to guideline-mediated therapy or device therapy, but in some cases may happen spontaneously. There are clinical biomarkers, imaging, and genetic factors which predict recovery. Patients with improved ejection fraction have a more favorable outcome compared to those with reduced and preserved ejection fraction, but less favorable to those who never had any heart failure. And despite a complete normalization of ejection fraction, a significant proportion may develop recurrence valve dysfunction. Heart failure treatment in these patients should be continued indefinitely, and a close follow-up of such patients mandatory. Thank you very much.
Thank you, Dr. Surya Banerjee. It was a fantastic lecture. I think we've covered almost all the aspects of improved ejection fraction, which is, I think, we are all seeing quite a number of patients. So my question is, when would you consider, at what point of time you will consider discontinuation or reduction of therapy? Or will you consider partial reduction of therapy, like maybe avoid aldactone antagonists first, move on then in stepwise fashion?
Yeah, I think the only study which we had, it didn't look at partial discontinuation. And I think every case have to be judged on its merit. If I have one of those patients, say, for example, who had a Takotsubo syndrome and have recovered, maybe in such patients, I may gradually think about withdrawing the therapy, maybe by step approach, and observe them very closely. Should they show any signs of deterioration, like increase in NT-proBNP or any of the more sensitive imaging markers, then I may again put them back on therapy. Apart from that, I think it may not be prudent, especially if the chances that the patient may be lost to follow-up, may be best to actually continue them on medical treatment.
Yeah, Shubhra, I have one query.
Yeah.
Whether this is a 10-point improvement or it is a 10% improvement in ejection fraction?
It's a 10% actually. 10 point is 10%.
Okay. And second query is, suppose in your clinical practice, you get an ejection fraction of 44%. How often it is going to be heart failure with mildly reduced EF, and whether this is a heart failure with improved EF, or both are the same?
I think this is a difficult question. I mean, unless we follow the trajectory, the evolutionary trajectory, we are unable to say whether it's an improved fraction, improved ejection fraction, or a mid-range ejection fraction. So once I find a patient who is in mid-range ejection fraction, and I do not have any documentation of his previous ejection fraction status, then it's vitally important that such patients are followed up closely with repeat echocardiographical parameters to see whether it's actually improving or static or they're actually getting worse. But in any case, I'm not going to stop the medication.
So one question.
One query, because you said it is 10% increase in the ejection fraction. Suppose the ejection fraction was, say, 30%. 10% of 30% is 3%. So at 33%, should we say that?
No, it's not 10%. It's actually, we said 10 points because 1 point.
That was the confusion actually. That's why I wanted to clarify. You please explain this part.
Yeah. So by 10 point, it means actually, see, the percentage is used, the term is used in different sense. When it's 10% increase, it's an absolute 10% increase from the previous echocardiographic ejection fraction. It doesn't mean that a 10% increase, it's not like 10% of 33. No, it's a 10 point. That's why if you look at the definition, they've actually used 10 point. And they have clarified. They have clarified also what they mean by 10 points.
Exactly.
And one question in the chat box that has come is what is the difference between spontaneously recovered patients and patients who have improved drug treatment? Is there a difference?
I think spontaneously recovered ejection fraction happens in a few cases perhaps. And these are the patients probably who are more likely not only to improve, but also perhaps to retain their ejection fraction, at that level. So, but again, we have to be a bit cautious about it. So, ideally, these are the patients probably where we can stop the treatment, medical treatment. But again, I think we still do not have that much data to say that it is safe to do so. If we are reducing our treatment and what is, which is often necessary from practical point of view, patients are on numerous treatment, and very expensive treatment. So we are tempted to reduce the treatment. If we really do so, then it's vitally important that these patients are followed up closely.
Yeah, and in a heart failure registry, 16% patients did not have recurrence of low ejection fraction even after stopping the treatment. So it's really a clinical adjudication where to stop, where to reinitiate. And we have seen in our experience that in majority of the patient, it does recur. That means EF does goes down if you stop at least the RAS blockade and beta blockade. I don't know about MRAs and SGLT2 inhibitors, but definitely in majority of the cases, it does recur. We'll close the session.
One is,
yeah,
sure. So 25% to 35% is not fulfilling your criteria. That is very interesting to note. So even 25 to 39%, 14% ejection fraction is not fulfilling. And Dr. Pandey, this is a very strict compartmental definition. So by 144% value, you can never say it is an improved. Improved has got in its definition the whole trajectory of the life. As Dr. Shubhra said, the trajectory. So without the trajectory, you can't attach a terminology of improved ejection fraction. So you have to settle for the term of mid-range or mildly reduced. You can't say improved unless you have got the whole trajectory in front of you.
Absolutely.
I think there is a little bit of a confusion growing up. One of the chairpersons, please give the concluding remarks.
I think the whole discussion about discontinuation is only when there is a complete recovery. And there's a partial recovery, I think there is the point of discontinuation is not there. Leave alone the numbers, leave alone the definition. Exactly. That is the most important thing.
Exactly. Absolutely. So thank you very much. Shobra, a wonderful talk, and it evoked a lot of debates as well. Good. Yep. Good from the academic point of view. Now I hand over to Soumitra.
Yeah, thank you, Dr. Guho. Actually, we have designed the program in such a fashion that now we have discussed to improve the ejection fraction by 10% or more. But how to do that? So there is a debate whether we can go for a sequential adding medicine after medicine and giving a gap of 4 to 6 weeks in between to see whether they are still effective or need something more, or we should go together and hit it on the Billi ko mardo shaadi ka raat mein aise, so kill the cat on the marriage night. So whether you attack with whatever you have got on the day one and see what happens. So with this fantastic idea now brewing up across the Atlantic, including India, we invite our chairpersons, Dr. Ranjan Sharma and Dr. Shunib Banerjee, to invite the speakers, and we'll keep the discussion at the end of 12 and 24 minutes. There won't be any rebuttal. Whatever you have to say, you speak your heart out, Bapaditto and Shumanto, and then we'll discuss for 6 minutes. So Ranjan Sharma and Shunib Banerjee, please.
Yes, good afternoon, everybody. It's a wonderful program that is being designed. And now we are deviating from treatment of heart failure from the guidelines, and some are just which approach is better. Let us understand from the two learned speakers. Dr. Bhapathi Kumar will talk on existing step care approach to be followed as it is described in the guidelines. Dr. Kumar, please.
Are my slides visible?
Yeah.
Yes. They are visible. Just go to full screen.
Yeah, I have gone to full screen.
Go ahead.
Go ahead. Good afternoon, respected seniors and my dear friends, and my mentor and Professor Santanu Guho sir for the opportunity. So over the next few minutes, I will be speaking on my part of the debate, the management of heart failure and reduced ejection fraction, whether we are going to follow the existing step care approach as mentioned in the guidelines. So basically, let me clarify what the debate is all about. So where we will be adding a AC inhibitor and a beta blocker at the onset, titrate the doses, then add a mineralocorticoid receptor antagonist, titrate the doses. If the patient is still symptomatic, you replace a ARNI for the AC inhibitors or ARB, and the newest entry in our heart failure armamentarium, the SGLT2 inhibitors. Whereas the recent proposed new sequencing by McMurray and the Milton Becker is that you add a beta blocker and SGLT2 inhibitor at the initiation. Within 1 to 2 weeks, you add a ARNI, and within 1 to 2 weeks, you add a MRA. So basically, you are adding all the 4 drugs within 4 weeks and then up titrate. My talk will be basically based on the 2 guidelines, the ESC 2016 guideline and the recently published 2021 ACC-AHA consensus decision pathway. Basically, we have been following this guideline over the last few years till up to say 2019. We have been following this ESC guideline. Patients with HFrEF comes to us. We add a AC inhibitor and a beta blocker. We can give either of the 2 at the first onset and add the other within 1 or 2 days. Then we up titrate the doses. The patient is still symptomatic and EF is less than 35%. You add a MR antagonist, up titrate the dose. The patient is still symptomatic. You can substitute ARNI for AC inhibitor or ARB for heart rate more than 70 on a maximum tolerated doses of beta blocker. You add a Fibril, and in patients who are still symptomatic, QRS duration more than 130, you can evaluate for the need of CRT. Meanwhile, during all this time, you give diuretics to relieve symptoms and signs of congestion. But some things changed in the year 2019 and 20 that has led to our discussion. The publication of the 3 trials, the Pioneer HF trial, which ushered in a new era for the increased use of the ARNIs, and the DAPA HF and the Emperor Reduced trial. Now, coming to the Pioneer HF trial, it showed that even just after admission of a patient with acute decompensated heart failure, after the patient is stabilized within hospital, within 24 to 48 hours, you can start with a ARNI. It has shown that after 8 weeks with treatment of the ARNI, there was further reduction of NT-proBNP levels, and at 12 weeks, the patients who received ARNI within the hospital had a lower risk of death and dehospitalization. This pioneer study ushered in a new era for the use of ARNIs, and it is the study that has led to the approach of direct to ARNI treatment. Coming to the DAPA-HF and the EMPEROR-reduced trial, Milton Packer was the primary investigator of the EMPEROR-reduced, and J.J. McMurray was the primary investigator of DAPA-HF. I have taken these names because these names will again prop up in an important paper. This trial showed that the SGLT2 inhibitors, empagliflozin and dapagliflozin, given in patients with heart failure and reduced ejection fraction in class NYHA class 2 to class 4, when given on the top of the established treatment of RAS inhibitors, the beta blockers and the MRS, improved fairly better on these SGLT2 decreased hospitalization and cardiovascular death irrespective of the diabetic status. As a result of which, we have some new opportunities regarding the use of the ARNIs and the SGLT2 inhibitors, but there are some challenges. Where do we put the ARNIs and the SGLT2 inhibitors now? What about the older heart failure therapies like digoxin and vasodilators? And when do we refer for ICD or CRT, or when do we do a ICD or CRT? This is the paper I was talking about, Milton Packer and J. McMurray, published in the European Heart Failure Journal, the interesting paper regarding the evidence-based sequencing of the foundational drugs of heart failure. Here they proposed to initiate the beta blocker and the SGLT2 inhibitor at the first onset of treatment, then to add a ARNI, and then to add a MRA. But evidences are very limited for this proposed new sequencing, and if this proposed new sequencing gains momentum, this paper is going to be a landmark paper for the management of heart failure and reduced ejection fraction. Coming to my portion of the topic, why we are really undergoing our major improvement is that there is a lot of therapeutic inertia while we are giving optimal medical management. In the CHAMP registry, it was seen that even after 12 months, there was only a minuscule amount of patients received optimal doses of the drugs. So there is a significant scope of improvement in optimizing GDMT. In a resource poor setting of India, where most of our patients are not able to take the SGLT2 inhibitors and the ARNIs, we have to rely on the guideline-directed medical management for further improving compliance so that we can improve the GDMT in most of our HFrEF patients. In Indian population, it was seen that patients who did not receive GDMT had almost a 53% increase in mortality than those patients who received GDMT. For our GDMT, we have trial evidence of more than 30,000 patient years. We have evidences for the Paradigm HF trial, from the CHARM trials, from the SOLVE trials, Consensus trials, and lots of trials. We do not need to speak each and every trial, but there is a data from 30,000 patient years regarding the optimal medical management for HFrEF patients. Still, there is a significant mortality of the HFrEF patients, and 5-year survival is only 50%. Although AC inhibitors and NIRB reduce mortality by 16 to 17%, beta blockers by 34%, MRS by 30%, but we are definitely missing something. So are we need to add more drugs? Are we needing to apply drugs in another fashion, or there is something we are missing? In fact, we are missing compliance of the patients. There are lots of drugs we are using for management of HFrEF. There is in fact a drug cocktail which increases the risk of medication errors, poor adherence to pharmacological therapies, inappropriate drug prescription, adverse effects, drug-drug and drug disease interactions, and most importantly, underuse of the effective treatment. So in Indian population, it is more prudent to stick to the established protocol of treatment rather than go to an unestablished protocol where there may be chances of drug interactions and underuse of effective treatment. In India, it is a healthcare resource poor setting. There is increased morbidity and mortality of our most heart failure patients, and quality of life is compromised. So with overwhelming heart failure and reduced ejection fraction therapies, there is a need to inform the clinicians about where evidence may be new and where there is more data is required. numerous care gaps exist and highlighting the need for more streamlined and efficient process implement the best practices for HFrEF patients. ACC-AHA guideline, if you go by this guideline, they recommend to either initiate a RAS inhibitor or a beta blocker. In some cases, both the therapies can be started at the same time, and this should be uptitrated every 2 weeks fashion to help HFrEF patients with optimal GDMT. This is the newest protocol they have set, the ACC-AHA 2021 guideline. This is more easy to use because they have advocated to use either of the 3 RAS inhibitors, but they had put forward a direct to RNA approach. I will come in my later slides. Along with this, they have advised to use evidence-based beta blockers. To uptitrate the doses for patients who are still symptomatic, that is NYHA class 2 to class 4, with the EGFR more than 30 and potassium less than 5, you add a aldosterone antagonist. For patients meeting the EGFR criteria with NYHA class 2 to class 4, add a SGLT2 inhibitor. For relieving congestion, you add diuretics. For persistently symptomatic patients on all these 4 classes of drugs, you add hydrolazine isotonic dinitrate combination, and ivermectin I have already mentioned for those with heart rate more than 70. This treatment algorithm is more feasible and more easy to use. Also, I would like to stress here is that they have applied the approach of direct to RNA because we have already known from the paradigm HF trial, RNA results in 20% reduction in the primary outcome of cardiovascular death and hospitalization compared to enalapril. In the PROVE HF trial, it was shown that RNA resulted in a better reduction of NT-proBNP and caused reverse remodeling effects after 12 months of therapy compared with enalapril. Evaluate HF trial, we got similar findings of the PROVE HF trial and there improvement in the echocardiographic parameters. HF already initiation of RNA during and ADHF episodes resulted in superior outcomes compared to enalapril. All this together led to a de novo use of RNA in our heart failure patients, and this is the result of which a direct to an RNA approach was applied in the ACC-AHA 2021 guidelines. But we must remember, though RNA beta blocker and mineralocorticoid receptor antagonist results in a mortality reduction of almost 63%, keeping in mind our Indian scenario where it is very much difficult for the patients to get empagliflozin and a circuitry valsartan together because of financial constraints, we can at least put the patients on AC inhibitor, beta blocker, and mineralocorticoid receptor antagonist because these 3 drugs also cause a reduction in mortality by 56% in the HFrEF patients. Now, coming to what are the approaches of SGLT2 inhibitors. SGLT2 inhibitors put on the triple drug regimen, that is the RAS inhibitor and the mineralocorticoid receptor antagonist, extends overall survival compared to conventional therapy. As a result of which, the SGLT2 inhibitors are recommended in patients of HFrEF who are already receiving these RAS inhibitors, beta blockers, and aldosterone antagonists. Remember that the 2 trials, the Imbalances trial as well as the DAPA-HF trial, used SGLT2 inhibitors on top of this guideline-directed medical management. They did not use SGLT2 inhibitors in de novo HFrEF patients. This is the most important thing that is to be kept in mind, because if we follow the new sequencing management, here we are using SGLT in de novo HFrEF patients. So I have already discussed this. Now coming to the explanations, forth by the rapid sequencing group, they tell that the traditional sequence does not necessarily conform to the known relative efficacies of the available drugs. But our counter argument is that GDMT has evidence from studies more than 20,000 patient years. The new sequence proposed does not have any RCT evidence for benefit. It is backed only by expert opinion extrapolated from other related studies. Also, after the introduction of the direct to RNA approach and the SGLT2 inhibitors in GDMT, there has been further evidence-based improvement in outcome of the HFrEF patients. Another argument is that even low doses of the drugs afford significant benefits, whereas the escalation of dosage adds only marginally to the efficacies, whereas initiating multimodal treatment even in low dose may exert greater beneficial effect. Our counter argument is that in GDMT, multimodal treatment is used in a more scientific way backed by evidence. There are affordability issues with RNA and SGLT2 inhibitors in the Indian population. At least a patient can receive a ACE inhibitor, ARB, a beta blocker, or a mineralocorticoid receptor antagonist. In the Indian population, where compliance is a major issue, instead of jumping to a new unestablished protocol, it is more prudent to follow the standard GDMT with an emphasis to improve compliance. And another opinion is that SGLT2 inhibitors may have a better safety and tolerability profile if we follow the new approach, because they can reduce the renal dysfunction associated with the RAS inhibitors, or they can mitigate the risk of early worsening heart with the beta blockers. But our counter argument is that without following a standard protocol, there is increased risk of adverse effects, metabolic abnormalities, renal dysfunction, and drug-drug interactions, and cost issues. Moreover, the two trials, the DAPA-HF and the Emperor Reduce, studied these SGLT2 inhibitors in patients who are on GDMT for FREF. This is the Canadian guideline. What they have proposed, I like this guideline because they have not discussed whether we are going to initiate beta blocker or SGLT2 inhibitor at the onset. Rather, they have put forward that we can initiate with all the 4 drugs. We can either choose a ACE inhibitor, ARB or ARNI. We can add a beta blocker. We can add a MRA and a SGLT2 inhibitor. Then assess the patients and ultimately uptitrate the doses at 2 weeks interval. That is studying the safety, tolerability, and efficacy of rapid optimization of the heart failure therapies. The results will be published in the late 2021. Till then, we have to wait for other evidences. So I have told my part, and I will be waiting eagerly to hear my dear friend and colleague, Dr. Sumanta Chatterjee, to his part on rapid evidence-based evidence-based treatment of the 4 foundational therapies. Thank you.
Thank you, Dr. Bhapathi Kumar. It was a wonderful speech, and you registered a new trend that is going to happen in the next. And many of us are believing that we will be moving towards what Sumanta Chatterjee will be taking. Let us see how he presents his case. Sumanta, please.
Yeah. Thank you, sir. Let me share my screen first. Dr. Bhapathi, please stop sharing screen. Otherwise, I cannot start my sharing.
Yeah.
Yeah. Thank you. A very good afternoon. Thank you, everybody, for giving me the opportunity here. So today is a debate, and the topic is for management of HFrEF, existing state care approach to be followed as in guidelines, as spoken by Dr. Bhapathi Kumar. And my topic is no. It should be replaced by a new algorithm for sequencing drug treatment. Actually, the thing is that the debate is not about the 4 molecules or the foundational 4 molecules. Everybody know that ARNI, SGLT2 inhibitors, beta blockers, and MRA. These 4 molecules are the pillar of the drug treatment of heart failure. And we know that heart failure is a devastating and worsening disorder. It is worse than cancer even. It should be treated in all multiple prongs from multiple corners. We know that around 70% of the cases of HFrEF is due to GAD. Type 2 diabetes mellitus is associated with 50% of cases of HFrEF. 20% mortality rate after hospital discharge within 3 months. 33% mortality rate within 1 year. In spite of knowing all these things, the utilization of GDMT is around 20 to 25%. And if you use GDMT in full scale, we can reduce 3 months mortality by about 72%. So this is a grim, bleak, slide to say the least, but it is representing that how severe is the disease. Whatever arsenal, whatever evidences, data, and treatment protocol we are having, from the very day one, we should utilize all these things. It is not the evidence, it is our experience. Whenever we are preparing a soup, maybe 4 ingredients are needed to prepare a soup. Number 1 is salt, sugar, some pepper, or cheese or something like that, or milk, something like that. It is not that we are using salt first, then adding up again salt, and then try to add sweet, and then try to add pepper. Then there is no point in tasting the soup. we are adding all the 4 ingredients simultaneously and upscaling it. At every minute or every 5 minutes, we are testing it whether the composition is right, and then adding another pepper or adding sweet or decreasing the amount of salt. This is the kind of thing where we are preparing the soup. This is the scenario. So why not here? Because the GDMT are saying that, guidelines are to guide. They are saying that definitely these are the fantastic 4 molecules. We have to add that thing, but we are starting with maybe beta blocker, then upscaling it. We are seeing that there is no competition. Then after some time, after few months, we are adding another molecule. But in our experience, if there is no complication and if the patient is not symptomatic, if the patient is symptomatic, then we are gearing up the next stage. But in our experience, what we do? We initiate beta blocker in very low dose. If the patient can tolerate, we see hardly for 10 days of 1 week or 10 days, and then adding up our next arsenal, maybe SI inhibitor or ARP or RP, then MRA or SGLT2 inhibitor. So whatever the sequence is. So the debate is what the sequence will be, especially in Indian population. What is the sequence? Beta blocker first, then RP, then MRA, then SGLT2 inhibitors, or the reverse? The debate may be regarding this. There is no debate that all the 4 molecules should be very first upscaled or very first introduced and then modify the dosing. So we all know this. This is a position statement. There's a one slide presented in ESC 2021. All the 4 molecules are enjoying class 1 indications. We know that beta blockers from CVS to Merit-HF, Copernicus, all the trials are saying that it is having 30 to 35% all risk, all-cause mortality and CV death reduction, heart failure hospitality reduction in the tune of 30 to 35%. MRA. Next line is MRA because it has the capacity to reduce it by 25 to 30% and HHF by 35 to 40%. This is the highest range. RNI 20% to 20 to 25%. SGLT2 inhibitors from Emperor reduce and DAPA-HF is in the tune of 30%, both in the cause of all-cause mortality of CV death or heart failure hospitalization. So all the 4 molecules in the tune of 20 to 40%, there we are enjoying the death benefit. So this is foundational paper for which this debate has given the table by Milton Parker and J.J. McMurray. So Dr. Kumar has already, this slide has already been presented by Dr. Kumar. This is the conventional sequencing SE inhibitor, ARB or direct RNI, then beta blocker. If we see that there is no symptomatic deterioration or there is no side effect after some time, if the patient is symptomatic at all, then MRA, then SGLT2 inhibitors. Up titration to target dose at each step typically requires 6 months or more. And we know within 3 months, there is around 20% death. Rapid sequencing, step 1, beta blocker and SGLT2 inhibitors. Step 2, ARNI. Step 3, mineralocorticoid receptor antagonist. So here lies the debate. What will be the sequence of introducing newer molecules? So this slide was taken from J.J. McMurray statement. Compelling proof of robust risk reduction with HHF and death, BB, beta blocker, and all the 4 molecules. Each foundation therapy is effective independently of others, acts through distinct pathophysiological mechanism. Clinical benefits occur rapidly and maintained. More benefit, introducing additional foundational drug has more benefit than treating existing drug. Early initiation of all the 4 molecules in 4 weeks facilitates early risk reduction, improve safety profile of others. One molecule may improve safety profile of others, like SGLT2 inhibitors may improve safety profile of MRA by reducing its hyperkalemia or by reducing the chance of dropping out. This is a step 1. Beta blocker is the foundational drug, most effective and rapidly acting drug to prevent sudden cardiac death by left ventricular remodeling in long-term management. If the patient is dry, this should be the first agent. Next is SGLT2 inhibitors from Emperor reduced, then DAPA-HF. Lots of data are coming that this should be included in the step 1 because it is non-hemodynamic drug. There is no up titration of dosing. Side effect profile is less. it may reduce the dropping out chance of MRA by reducing its hospital admission or by reducing its hyperkalemia, and it is renal safe and renal beneficiary. We know that more than 20 or 30% patients of heart failure ultimately live in cardiovascular syndrome or chronic renal failure. In that front also, SGLT2 inhibitors can act. Hardly, I mean, if the patient is not dry, that is, patient is wet, then this can be your first molecule. Earlier osmotic diuresis, rapid reduction in risk of heart failure worsening, kidney protection. Initiated at therapeutic dose without requiring dose titration. So whether the patient is having, all-cause mortality, cardiovascular death, they are faring. If either the patient is having ARNI or not receiving ARNI, Emperor Reduce showed that consistent reduction in risk of CV death and heart failure, regardless of ARNI use. And benefit starts from day 12 and sustained throughout. This is also very much important. Patient is having ACVD or not, in any spectrum, it acts. Like heart failure, atherosclerotic disease, CAD heart failure, heart valve disease, patient is having atrial fibrillation, chronic kidney disease, in all the spectrum it acts. That's why it is included in step 1. Step 2 is ARNI. We know that it is a very important molecule. This one slide, there is Pioneer HF, starting of ARNI in acute decompensated patient after stabilization in hospital. Transition means transition from ICU to general ward or during discharge, then Paradigm HF, and then Prime HF, Prove HF, Evaluate HF in atrial fibrillation patient, mitral valve regurgitation patient to reduce the improve the ejection fraction, and the LV parameters will improve. Atrial fibrillation may improve in cases of ARNI, that we already know in direct to ARNI approach given by Dr. Bhapathi Kumar. So this is the ARR and NNT 19, 21, and 22. Empagliflozin and ARNI. This is the statistics we can quote. And lastly, MRA is a very important molecule. Significant reduction in mortality, morbidity. Background use of SGLT2 inhibitors and ARNI may lower the risk of or worsening kidney disease and hyperkalemia. The reason we exactly do not know. From ARNI, from FSS and RELS trial, we already know these things. Empagliflozin use or SGLT2 inhibitor use may be associated with 22% lower risk of discontinuing MRA therapy in patients with HFrEF. It's a very much important thing. One molecule is reducing the chance of dropping out of other molecules. So, if the 4 molecules are added up simultaneously or in rapid sequence, this will benefit the patient. They may benefit the patient. So this is CCS, Canadian Heart Failure Society Guideline 2021. Initiate all the 4 molecules standard therapy as soon as possible and titrate every 2 to 4 weeks to target or maximally tolerated dose over 3 to 6 months. So contradictory to your guideline recommendation of 16 or 19, we are having this statement that all the 4 molecules will be there in your system by 3 months in maybe in standard dosage. At least we should try, because it is like a cancer and it is a devastating disorder. We should try all our strength to act maybe simultaneously or within rapid weeks. So this is another NFS with optimizing therapy with need for speed. This is a new term, that is comprehensive disease modifying medical therapy, CDMMT. Here the change we know here: CV death, heart failure hospitalization death, CV death or hospital hospitalization death, or emergency urgent visit for worsening heart failure. The change is minus 40% to minus 60%. So this slide, this is 2021 heart failure ESC, HFA ESC slide. That is 9. How can we sequence the foundational 4 molecules? We can categorize the heart failure patients in 9 categories. Low BP, high heart rate; low BP, low heart rate; normal blood pressure, low heart rate; normal blood pressure, high heart rate; AFib normal blood pressure, AFib low blood pressure; CKD or hyperkalemia; pre-discharge, and patient is having hypertension despite GDMT. So they have categorized the 9 strategies of heart failure by which you can strategize that these patients should get beta blocker first, these patients should get ARNI first, these patients should get SGLT2 inhibitors for. But nobody is denying that all the 4 molecules should be used in rapid succession, if not simultaneously, so that heart failure patients can be given some extra years. So this is my last slide, that if we use all the 4 molecules at the age of 55, you can add 6 years in his lifetime. 65, you can add 4 years. And at the age of 80, we can add 1.5 years to his lifetime. So we know that heart failure develops in our country maybe 1 decade earlier, maybe in the 50s or in the 60s. So we can add around 4 to 5 years productive life. You can we can add these 4 foundational molecules in rapid succession, if not simultaneously. Cost, if we can afford CRT, definitely we can afford it. Compliance, I don't know. In pandemic situation, if I go by road, we doubt that what is the compliance in our population, basically. In respect to mass only, that we I don't know. I doubt it. Thank you. Thank you.
Thank you, Sumanta. So you have proposed a new thing, and new proposals are always, there are many inhibitions and many resistance that you have to face. And the new things may not be always good. We hope that it should be good, but it may not be good. So let us hope that in future we can have some outcome trials that is in a better way. But let us hear from Pandito what is his comments about his proposition.
Sir, basically my approach is that you add all the drugs, but follow the guidelines, because it will reduce the complications, it will improve the compliance, it will reduce the hypotensive side effects, and all this will help us, because the protocol is already established for last 10 years. So just the new drug SGLT2 inhibitors has already received a class 1 recommendation from the ACC/AHA. So there is no harm in adding the SGLT2 inhibitors after we have already started these 3 drugs. So my approach is add all the drugs, but take time to add all the 4 drugs.
Shunip is there?
Yeah. Shunip, you give your comments, please.
We are waiting to hear your comments.
Thanks. I think they have all said the right thing, but for practical purpose, what I do and everybody should do, reconfirmation of your diagnosis of FREP, and I will request everyone to do the echo, see the echo Doppler at least yourself, that you don't miss any reversible, correctable thing. And remember one thing, this new hue and cry on SGLT2 and RT is on the top of beta blocker and AC inhibitor and MRF therapy. So you need to discuss what the patient wants also. How much he can go, how much he can afford. That's more important. And I have seen a different perspective also, that patient with a creatinine of just 1.5, the nephrologist have stopped AC inhibitor or RNI. This is not the case should be done. They should be continued even with mild rise of creatinine. And hypovolemia is a real issue, and everybody has to be careful not to give unnecessary nitrate diuretic. And both Bhapathi and Sumanta, you were right, and actually what you said, you didn't debate, you actually agreed with each other, and that is the approach. Thank you.
Thank you, sir. Thank you.
Thank you. I think that we are going behind time. So thank you, Bappa and Sumanta. Thank you very much. The chairpersons, Ranjan and Shunip. So let us move to the next subject. Soumitra perhaps loves playing with the words and has a knack for dancing as well, because next session he has termed dancing with the rhythm, and he being the first speaker. May I invite the chairpersons, Dr. Dilip Kumar and Zabir, you are here by any chance?
Zabir is here.
I'm here, sir. Good evening.
Good evening. Please take over the session, and Soumitra will speak on subclinical AF, evaluation and management. Over to you.
Thank you. Thank you, sir. So this is something new which we are coming across nowadays with the ever-increasing use of the cardiac devices, the implantable cardiac devices and the wearable cardiac devices. We are quite clear about the clinical AF, its problems, the management, and anticoagulation treatment to prevent stroke. Are all these things in clinical AF? Can we apply it into subclinical AF? We do not know, because the subclinical AF of variable duration that is detected by the asymptomatic episodes of atrial fibrillation, and it's detected by the wearable devices. Is it only an accidental thing? What is its clinical relevance? How do we manage it? Is the stroke rate similar to that of clinical atrial fibrillation? What is the progression to clinical atrial fibrillation? So there are a lot of questions which request answers. Some are guided by certain data in the form of meta-analysis, as well as data we derived from the randomized controlled trials, and a lot of data which is expected to come in the future from the ongoing clinical trials like Artery and other trials with apixaban. So we have to discuss this extremely important topic. We have none other than Professor Dr. Soumitra Rai, who I don't think any introduction is required. Wonderful speaker, great academician, and a person who is so known across India in the cardiology circle. Dr. Soumitra, please.
Thank you, Javed, for your sweet words. Thank you, Professor Guho, and all my colleagues and other chairperson. It's very unnerving to talk anything about rhythm when Dr. Narasimhan is already logged in. So please excuse me if I fumble. And another request to the back office that don't give that sheep-like siren when I end. It is very disturbing and unnerving. Just say that, Doctor, your time is over. That will be much more practical way. So my talk will be based on 2020 ESC guideline on the atrial fibrillation. And while preparing this talk, I rediscovered the definition of subclinical aortic atrial fibrillation. I had some different idea about it, but I have changed my idea. What is it? It is actually defined as episode of AF or atrial tachycardia with duration of 5 minutes to 24 hours detected in patients without clinical history or symptoms of AF. That is for screening. And if you see on the right, if it is device detected, then what is the definition? Then AHRE more than 6 minutes but less than 24 hours with lack of symptom in patient with an implantable device detected with continuous ECG monitoring, which is intracardiac, but without prior diagnosis by ECG or Holter. So it's a very watertight definition and sometimes very gray area of definition. Now, no symptom attributable to AF and not previously diagnosed with clinical AF, you detect it by the implantable device. Now, what to do? You do an ECG. If the ECG shows AF, it's a clinical AF. But if ECG does not show AF, then it is subclinical AF. So it's a very handful of patients who are not looked upon even 10 years ago, but over the last 10 years, you can see there is explosion of trials on these. And there are explosion of devices. Some are medically directed, some are commercially directed. And if we see the intermittent monitoring to continuous monitoring and come from non-invasive to implantable device, it's Apple Watch, it's Zio Patch, it is Mayo Clinic device, it is Medtronic device, and it is implantable cardiac monitor. So it can be just a simple watch to implantation operation, what you can do for. And they are different in their sensitivity and specificity. If you see, they are very sensitive to pick up the AF or so to say irregular rhythm, more than 90% each of them. But the specificity varies widely from 70% in pulse taking to up to 100% in smartphone apps. What to do with this data? There is a progression of atrial high rate episode. When you detect, if you see the left panel, the 5 minute to 1 hour episode, within next 6 months, how many will go or progress? So if you see that 5 minutes to 1 hour, only 5% will go for a day or more of atrial fibrillation in 6 months. But if it is 12 hours to 23 hours, 63% will develop a more permanent AF within next 6 months. And now, what about the stroke? Stroke depends on the CHA2DS2-VASc score and what is the duration of AF. Even if there is no AF, there is some risk of stroke if a very high CHA2DS2-VASc score. But if it is 6 minutes to 23 hours, vis-a-vis more than 24 hours, there is some difference, particularly in the lower values of CHA2DS2-VASc score. But on the higher values of CHA2DS2-VASc score, very surprisingly, there is no difference of stroke rate. Now, so the ESC has recommended that opportunistic screening of AF by pulse or ECG rhythm strip is recommended on everybody above 65 years. So these are the vulnerable people when you should be go for head hunting and for proactive detection. Also, it is recommended to interrogate the pacemaker and implantable cardiovascular defibrillator on a regular basis for AHRE. When we implant a pacemaker, we just are interested about the battery life. Okay, battery life is fine, then go on. We don't have to see you. But it is mandatory to check the atrial high rate episodes when you have got the opportunity of a pacemaker inside the body. It is mandatory. We don't do it many times. Now, when screening for AF, it is recommended that the individual undergoing screening are informed about the outcome of the screening and its relevance. It's almost legally important. He might say, hey, doctor, you have detected something in me. Now what to do with this? Why didn't you explain that there will be so much problem in my life if you detect it? Then I wouldn't have subjected myself. So that is very interesting. A structured referral platform should be organized beforehand. And definite diagnosis of AF in screening positive cases must be done with an ECG which show at least 30 seconds of AF. So screening does not lead to anywhere excepting leading it to a specialized clinic. Nothing more, nothing less. Now we know who are susceptible to this opportunistic screening positivity. Aged and male patient with some ethnicity and genetic, a lot of comorbid condition. And obese, hypertensive, OSA, COPD, CKD, diabetes, and so on. So if these things are present, you are more proactive to hunt for the atrial fibrillation. If you see the blood pressure, no blood pressure versus hypertension, there is high risk of atrial fibrillation in hypertensive people. 140 systolic versus 130 systolic target. Twice as many AF in 140 systolic target hypertensive patient. Hypertension with LVH, without LVH. Twice as many AF patient in LVH with hypertension. So these are the clinical cues. Elderly patient, 140 and more blood pressure, LVH with blood pressure, they are supposed to have atrial fibrillation if you look carefully. So hypertension in sinus rhythm, but when you suspect AF, if there is a cryptogenic stroke, as I mentioned, certain other parameters, age, etc., then frequent opportunistic screening. If it fails, long-term non-invasive ECG monitoring. If it fails, implantable cardiac loop recorder. Depends on how strongly you suspect of an underlying atrial fibrillation. Now, what to do with this atrial fibrillation? Now, if you detect atrial fibrillation clinical, you know that standard protocol, everybody, even a child knows how to treat an atrial fibrillation nowadays. But what is the subclinical thing? Incidental finding on implantable or wearable device, incidental finding during monitoring for other cause, and detection during the embolic stroke of undetermined source. What to do? High false positive rate for device detection, uncertain impact of symptom status and the burden of the disease, and uncertain role of anticoagulation. So you are more in a soup. So what are the advantage or benefit of detecting this subclinical AF? You can prevent a stroke, you can prevent a symptom. You can prevent electrical atrial remodeling, you can prevent an hemodynamic derangement and cardiomyopathy by upstream treatment or proactive treatment. You can prevent AF-related morbidity and reduction of other associated conditions. But what are the risks? Abnormal result may cause anxiety, with more hypertension and actually precipitation of atrial fibrillation due to anxiety. ECG misinterpretation result may lead to overdiagnosis and overtreatment. And very interestingly, ECG may detect other incidental abnormalities, which were not supposed to be detected and treated for another 10 years. And then you do an angiography, You put a stent, you do a bypass surgery, you put an ICD, and which causes more harm than good unless the patient has got enough reason to go for these parameters. Now, the current vision of International Society of EHRA 2017, duration has to be more than 5.5 hours. CHA2DS2-VASc score must be permissible to do the oral anticoagulation. Otherwise, you don't look into it. If the CHA2DS2-VASc score is low, don't hunt for atrial fibrillation. You won't gain anything by detecting that AF. If CHA2DS2-VASc score is high, then only there is some reason, some rationale to go for it. Now, cryptogenic stroke and underlying atrial fibrillation. If there is a cryptogenic stroke, patient in sinus rhythm, and if you hunt for atrial fibrillation by standard versus the implantable device, in 6 months, the detection rate is 2% versus 10%. In 1 year, 2% versus 15%. In 3 years, 2% versus 30%. So you see that 2% remains 2%. Even after 3 years, if you don't do anything. But if you put an implantable cardiac device, with every year, you are detecting 10% cases of atrial fibrillation, so that at the end of 3 years, 1/3 of patients are candidates for oral anticoagulation, so that you can prevent a second stroke, which is important. Now, if you see the duration of AF, more than 23 hours versus no AF, and there's of course between 0 and 23 hours. But if you see the two extremes, you will see there is a huge gap of stroke associated with this atrial fibrillation, either more than 24 hours or less. So lesser the AF burden, lesser the chance of stroke. The ASSERT study published 3 years ago, duration of device detected subclinical AF and the stroke chance. So if you take the 6 minutes as cutoff, you will get 40% people detected to have AF. If 6 hours, it is 20%. If you get the standard as 24 hours, still you will get 10% people getting the stroke. But only if it is more than 24 hours, that is clinical AF, then only the stroke risk is really high. In the other area, 6 hours to 24 hours, 6 minutes to 6 hours, they don't have much increase of stroke risk. So there is some contradiction. So if you have an ischemic stroke in sinus rhythm, do the ECG monitoring for 72 hours. No AF detected. Additive non-invasive ECG monitoring based on the risk stratification. Only, as I mentioned, if you think the patient has got high chance of AF, then go for the invasive monitoring or 30 days extra monitoring. But if you see it is a low risk, just forget it for the time being. So recommendation for the search of AF in patient with cryptogenic stroke by ESC last year, in patient with acute ischemic stroke or TIA and without previously known AF, monitoring for AF is recommended using a short-term ECG recording for 24 hours, then 72 hours. And in 2A recommendation is that in selected patient without known AF, additional ECG monitoring, long-term non-invasive monitoring, as well as interventional monitoring to detect AF is class 2A recommendation. Treatment of subclinical AF, does 1 + 1 always equal 2? A very interesting article published in Circulation. Subclinical AF doubles the risk of stroke, particularly in elderly hypertensive patient on pacemaker or ICD. If you detect a 6 minute or more AF, there is 2.5 times more stroke. Clinical AF, whether symptomatic or asymptomatic, and paroxysmal or persistent AF you are treating. So why not subclinical AF? What are your symptoms to do with the risk of stroke? If there is AF, if it is for 10 hours, so why don't you treat it? What about some people have more tolerance, they don't complain about palpitation. So why should it be judged by clinical parameters? But hence ASSERT and IMPACT all show no association between AF and the stroke in terms of temporal relation. No AF is recorded in the preceding month. Even when there is a stroke, AF was not recorded within 1 month of that stroke. So it is not causally relative. Is it only a bystander marker? And episodes of at least 24 hours is actually increasing the stroke risk, not 6 minutes, not 6 minutes to 23 hours. So what is the point in detecting this? So actually, we are trying to find out by the Arteria trial and the NOAA-FNET trial. Pending the results of these within the next 2 to 3 hours, if you get a patient, you can enroll these patients into these 2 trials, or it's up to you. If it is more than 6 minutes duration and the pulse rate and the rate was 180 per minute or more, then you very carefully think about the CHA2DS2-VASc score. And if the CHA2DS2-VASc score is 2 or 3 or more than that, then you really go for hunting for this AF detection.
So sorry to
When to give anticoagulation? Yeah, I'm finishing. In primary prophylaxis, depending on CHA2DS2-VASc score, ESC is very wise. They didn't give any watershed cutoff. They said at CHA2DS2-VASc score increases, your threshold for giving the anticoagulation decreases. And as the duration of AF increases, your threshold for giving the anticoagulation also decreases. So there is no watertight compartment, but depending on the CHA2DS2-VASc score and the duration, you decide what to do. So I summarize, my friend, subclinical atrial fibrillation is an AF detected in asymptomatic patient without proven AF but suspected. SCAF is not uncommon, especially detectable after cryptogenic stroke or people with high risk of stroke, as I described. Signs of atrial myopathy without detected AF are not currently sufficient to initiate any oral anticoagulation. The diagnosis of AF on post-stroke monitoring requires documentation of an ECG of sufficient quality to allow confirmation by a trained person. And the concept of ESAS has not been proven to identify patient with stroke who can benefit from OSE. Fulfilling the criteria is neither an indication for NOAC treatment nor the withholding of prolonged ECG monitoring. Patient with ischemic stroke or TIA should have at least 72 hours of Holter monitoring. Cardiac imaging marker, etc., should reduce the threshold of invasive monitoring for AF. The AF detection rate after cryptogenic stroke is a function of length of monitoring, how long do you monitor, and what the definition you give, 6 minutes or 1 hour or 23 hours. At present, it is controversial how to manage an incidentally detected SCAF in terms of arrhythmia prevention and stroke prevention. So, sir, from this so beautiful area when we could detect the atrial fibrillation, I still love this approach. Unfortunately, we have this approach, a very smart approach, so to say, but quo vadis domini. Where are we going for detecting AF? Are we directed or are we misdirected? Thank you.
Thank you, Dr. Soumitra. It was a fantastic talk on this new topic. I must say, this is a topic of high relevance because of the increasing use of devices, and we may be detecting a lot of episodes of atrial fibrillation, not clinically detectable, not previously detectable before the implantation of these devices. Now, what to do with these patients? There are 2 questions. One, are we supposed to do something to prevent the episodes of atrial fibrillation, to reduce the burden of atrial fibrillation, so that we should prevent the atrial cardiomyopathy or a chance of development of heart failure? Second, what is the need for stroke prevention in atrial fibrillation? You have clearly told that there are 2 most important situations where you need it. One, when the CHA2DS2-VASc score is high, otherwise there is no point there. It may be only an innocent bystander. There is no point in hunting or chasing these events. Second is patients who had a cryptogenic stroke and now they are found to have a asymptomatic or subclinical atrial fibrillation. This is important, where you have to, any duration of atrial fibrillation may be important in terms of stroke prevention in atrial fibrillation. So what is your take-home message? I think due to the short the time constraints, what is your take-home message of when we detect the subclinical atrial fibrillation, what should we do? Dr. Soumitra?
The first question you yes, I'm there. And to hear me?
Yeah.
Some break in your voice. There is some problem with your bandwidth.
Javi, you have posed a very important problem which I did not touch upon. Is not the what we call the upstream therapy, and there is evidence 2 ways. One is if we reduce the risk burden, like the range of blood pressure, like the obesity, like the COPD and the hypoxia damage. This is very important. And number two, there is some proactive treatment, particularly like ARB, angiotensin receptor blocker, has proved to prevent the first episode of atrial fibrillation in a clinical atrial fibrillation. There is some evidence. I'm not saying full evidence. Surprisingly, beta blocker fails here. Rather, ARB is better over here. So there is something we can do, even not going into oral anticoagulation, while we detect this subclinical atrial fibrillation by reducing the risk, and if in addition of an ARB, if possible, if the conditions allow. That's my submission is.
Dilip?
Yeah, I think it was a wonderful presentation, and Dr. Ray has almost clarified most of the points. One small point from my side: how much weightage and kind of importance you are going to give to PPG-based devices, wearable devices, whether you'd be going for anticoagulation or some therapy. Those patients who like Apple Watch or maybe some Fitbits, which tells you that with algorithms that there is atrial fibrillation, very varying R interval. They have come up with the algorithms that this patient is having more than 24 hours atrial fibrillation. Would you like to go ahead with therapy, or would you like to reconfirm with ECG-based devices or implantable or external patches and ECG-based, kind of confirmation of atrial fibrillation?
We have to wait for those results of two big trials. That is number one. And for the time being, I would say it's better to wait and prove it clinically by ECGs, or you admit the patient for a few days and see whether there is anything detected, something like that. Not on Apple-based. You can hook on the patient for a lifelong oral anticoagulation with all its hazards. I am against it. Maybe Dr. Narasimhan will say something on this, please, sir.
Nothing. I tend to use this. If a patient truly has an true indication is when the stroke is of undiagnosed origin, you want to prevent a second stroke. And by imaging and the TOAST criteria, it suggests the intracranial vessels, everything is normal. We do a D-dimer soon after an episode. If D-dimer is elevated, I presume that the patient has had an past history of AFib. And I don't do monitoring. I recommend anticoagulation to these patients if the CHAT score is more than 2. I don't think we achieve anything more than that.
That's interesting. Always something new to learn from Dr. Narasimhan. Great. Thank you, sir.
Dr. Soumitra, can we put it as all subclinical AFs may not require a particular treatment, but there are some subgroup of patients in the subclinical atrial fibrillation who require treatment to prevent further episodes of atrial fibrillation, to reduce the atrial fibrillation burden as well as stroke prevention.
Conclusion. That's the conclusion we can draw at the moment. Yes, Dr.
Just one question, quick question. Like you did mention about the duration for diagnosis of AHRE or subclinical AF. You did mention about the duration of the episode, but what about the rate? Do you think the rate is also important?
Yes, it is mentioned 180 or more. I have given in one of the slides. More than 6 minutes episode, and the rate, the ventricular rate will be more than 180 per minute, or at least 180.
I think we should come to an end of this session, a wonderful session, rather a new one. So let us move to the next one. To chair the session, may I request Dr. Rakesh Jadhav and Dr. Shuchit Majumdar to come in as chairpersons and to speak on the subject, bundle branch block in ECG. Actually, the original title, I kept it, when one should be cautious. But Dr. Narasimhan wanted to have a little different title. So it is up to him. Dr. Narasimhan, please go ahead with your deliberation.
Thank you, Dr. Guha. And I think Dr. Narasimha is our teacher, and he's a teacher of everybody. He teaches what we try to preach and what we try to practice. And this is a very important topic because invariably you find bundle branch block on ECG. So to know what significance of bundle branch block is, when to pace, when to ignore, when to go for further investigation, I think none other than Dr. Narasimhan can explain in the best possible way. Dr. Narasimhan, sir, please.
Thank you very much, Dr. Yadav and Dr. Guha. I've kept this talk a little more basic and clinically oriented, so pardon me if some of the concepts are very basic. As you all know, the initial vector in a right bundle branch block, this is the sternum, this is the vertebra, and in all of us, the activation is from left to right of the septum, which inscribes a small R, and then a very delayed activation of the right ventricle leads on to the R prime, which is very tall and delayed. So that defines the right bundle branch block in terms of electrophysiological characteristics. However, the biggest problem is in several patients, it can be a normal finding. Also, it is a marker of structural heart disease like hypertensive heart disease, coronary disease, and especially pulmonary disorders. So even though by itself, it may not indicate a need for a pacemaker, it will tell you that you need to investigate this patient further. For example, for diastolic heart failure, for hypertensive heart disease, there is some diffuse interstitial fibrosis that is going on that preferentially affects either the conduction system in terms of fibrosis or calcification, intravascular calcification. So you need to take a little more holistic view about this in terms of treating the patient. For example, these things are very common in people where the calcium phosphorus ratios are abnormal in renal failure. Extrinsic calcium can cause the problem. So when you have a person with a bundle branch block and syncope, very often it's neurocardiogenic syncope versus is it a true arrhythmic syncope is the question. Here, more than the ECG, you go by history. An abrupt onset of syncope, absence of prodrome in a person above 50 with bundle branch block, we tend to err on the side of giving a pacemaker because very often tilt test may be falsely positive and an EP study may not be able to throw some light on this. However, there are certain clinical characteristics. For example, if you see a QRBB, that tells you that the patient has a septal fibrosis. It may be an old infarct or a dilated cardiomyopathy or a HCM, which may be causing, and you have a lower threshold for giving a device. However, if a patient in addition has poor tissue velocities in this situation on echo, it could still be not a bradycardic syncope, but a VT could be a reason for the syncope in these patients. The second is when you see a patient with syncope and he comes to with a sinus tachycardia and he has a right bundle branch block, one of the causes which presents as syncope and right bundle branch block is an acute pulmonary embolism, which presents typically with an S1, Q3, T3 and a sinus tachycardia. You falsely see a small transient AV block and start working up the patient for a pacemaker. You may miss the underlying diagnosis in these patients. Third is not all right bundle branch block are always related to conduction system disease. The clue is the amount of delay and slurring that you see in R prime. As I told you, the second half of the QRS, which is the R prime, is a delayed activation of the right bundle. If it is very diminutive in voltage, if the voltage of the second component is very diminutive, it suggests a diffuse muscle disease of the right ventricle, and ARVC should be considered in these patients as a delayed epsilon wave masquerading as a bundle branch block. This is typically the pattern. Instead of a sharp upstroke, a very delayed and a diminutive R prime. So in contrast to a typical right bundle branch block where the delayed component is tall and robust in its voltage, patients with ARVC will have a very diminutive R prime and much more delayed than normal. The other condition is the company it keeps. When you have a person with a right bundle branch block and the PR is also prolonged, you need to think whether there is some diffuse conduction system disease or something else going on. If the voltages are all tall, one of the differentials diagnosis is a forme fruste of HCM. But if you start seeing this kind of Q waves, spiky Q waves all over. HCM is a differential, coronary artery disease is a differential, and patchy fibrosis due to granulomatous disorders like sarcoid should be considered. The reason why this is important is because just giving a pacemaker alone may not suffice, because giving a pacemaker 2 years later, he'll come as a dilated cardiomyopathy because of a progression of underlying disease in these patients. Similarly, when you have a diminutive voltage of the R prime, which is accompanied by vesicular blocks, it again draws your attention to a condition like sarcoidosis or a tuberculous myocarditis, when you have a diminutive R prime component with vesicular block or prolonged PR interval. So not only is pacemaker required, but you need to work up these patients for an additional disease beyond just giving a pacemaker to a patient. The third condition, which can again present as right bundle branch block, is conditions like Brugada syndrome, where the typical ST elevation can be masked when they develop a right bundle branch block. The clue to the diagnosis is the base of the triangle of the R prime is very broad. That is, if you take the R prime, the second component, it is a very broad, slurred, and therefore the base will be very wide in comparison to a typical incomplete right bundle branch block, where there is a spiky R prime. This should make you suspect that it is probably Brugada, and you need to move the ECG V1 one space up to confirm the diagnosis, if necessary, with pharmacological challenge. And again, the right bundle branch block like pattern may indicate this kind of a typical notching that is seen in inferior leads, which should serve as a marker for underlying left to right shunt, especially at the atrial level. We have had this kind of situation where patients come with right bundle branch block and they mistake this as tachycardia, and repeated cardiac shocks are delivered. Remember, large anterior MI in a young person immediately can trigger a surge of adrenergic response, and they have a marked tachycardic response compared to older people. And therefore, this is typically a young smoker with large anterior MI coming with a heart rate of 150 and 160. And the clue is to look at one particular lead anywhere where you see a P followed by a QRS, P followed by a QRS. And if this is accompanied by an ST elevation in AVR, this may suggest a left main occlusion, which should not be mistaken as VT, because this patient very often are coming to casualty with very rapid tachycardias and repeated shocks, and amiodarone is started, missing the underlying diagnosis in these patients. Sorry. Now, when you have a patient with a right bundle branch block and comes to you with syncope, when do you decide that this is malignant or which requires a pacemaker vis-a-vis a benign right bundle branch block? One is if the PR is prolonged or even upper limit of normal in such a patient, or if they have a posterior fascicular block. Posterior fascicle seldom gets involved in conduction system disease unless it's a diffuse conduction system disease. And very often these people will progress to develop complete AV block, and we will have a lower threshold for giving a pacemaker for these patients. Again, when you sit in the casualty and the patient comes to you with hypotension and comatose situation, and it looks like a right bundle branch block with delayed second component and notching, and there is a delayed second component in AVR, one of the differentials is something like a diffuse sodium channel blockade. Several drugs we use in clinical practice like amitriptyline, tryptomer, tricyclics. Of late, we have been seeing cocaine, which is young adults coming with cocaine poisoning, can present with altered sensorium and a right bundle branch block like pattern. You should consider this because immediately you need to start them on sodium bicarbonate, which will normalize some of the hemodynamic abnormalities before giving any other ionotropes to these patients. Switching gears to left bundle branch block, as I said earlier, the initial activation in all of us is through the left bundle and a left to right activation that gets disrupted in patients with a left bundle branch block, especially if the left bundle branch block is accompanied by left anterior fascicular block. So the sequence of activation will be from the right side of the septum, this aspect of the septum where the posterior papillary muscle is inserted. So you will have a posterior papillary muscle contracting with the septum and a very delayed lateral wall activation and an eccentric contraction of the lateral papillary muscle leading on to eccentric mitral regurgitation in some of these patients. So left bundle branch block can be a relatively asymptomatic finding in a person with hypertension and LVH, but can lead on to progressive ventricular dysfunction or present as syncope. Again, the typical criteria is 120 milliseconds or more, and we typically look for a notching or a slurred R wave in V5 and V6, and the RP time is prolonged. Why is this relevant? Because if you look at it, the transeptal activation time, you're seeing the sternum, the interventricular septum, the right bundle gets activated first. From the right to the left, it takes about 40 milliseconds, and another 40 milliseconds, the whole of endocardium gets activated. Then the second notch is predominantly because of a late activation of the epicardium. Now, why is this relevant in terms of looking at an ECG and deciding whether a patient is going to respond to conduction system pacing or you need an additional left ventricular lead? This is what the ECG should tell you. The initial component is sharp, which is due to endocardial activation of the left ventricle. The delayed component is because of the epicardial activation of the left ventricle. The taller and the broader and more notched the second component, it suggests that it's probably better to put a left ventricular lead rather than correcting it by just fixing a lead in left bundle itself. So the second component, the height and the width, tells you the amount of muscle that you are likely to recruit by placing an LV lead, and therefore this patient is likely to respond very well if the second component is tall and fat. Now again, it makes a lot of difference to understand whether this bundle branch block is rate related, and physiologically all of us know with a transition from a particular heart rate to a faster rate, the bundle branches can physiologically block. If it is right bundle in long term, it doesn't seem to have much of a prognostic implication, but patients with a left bundle branch block, which develops during tachycardia, can develop a syndrome similar to angina. And this is called a painful left bundle branch syndrome, where they present exactly with typical angina because of a delayed epicardial squeeze of the epicardial vessels, and they truly have lateral wall ischemia in this situation, which is functional, and they can be corrected by left ventricular free wall pacing. In contrast to that, if you have a patient where the QRS is narrow, but when the heart rate decelerates, you get a very wide QRS. This is malignant, this is pathological, and this indicates phase 4 block, and phase 4 block usually happens in a diseased bundle branch. And if you see this in a person with syncope, you will have a very low threshold for giving a pacemaker for that patient. The other thing which we forget is when you have a person with a pre-excitation and a left bundle branch block-like pattern, if it's a pure pre-excitation, the right-sided pre-excitation itself can cause some LV dysfunction. Getting rid of this pathway may correct the ventricular dysfunction as well as you may be able to correct the QRS. However, one of the subsets, some of the hypertrophic cardiomyopathy variant like AMP kinase mutate, PRKAG mutations can present with this kind of a syndrome where they will have a pre-excitation and a very tall QRS and lateral leads, and you should carefully look at the echo before just jumping and doing an ablation on these patients. When you are uncertain, when the patient's history is uncertain, when you are not sure what to do, you can, a very rare situation, you may consider doing a his bundle study in them. If you demonstrate a very prominent HV prolongation, which worsens with pacing or gets blocked, you may consider giving a pacemaker for a given patient. So the EP study is restricted to an occasional situation when you're not able to decide clinically what is required as a next step. Switching gears, among patients with left bundle branch block, it becomes because the initial vector in the septal activation is altered. There is a difficulty in diagnosing acute MI, and Scarbosa criteria would be useful to make a diagnosis. This is a typical example where the patient has an ST elevation in the lateral leads in the presence of a left bundle branch block, and patients has atrial fibrillation, and this patient should be immediately either taken to cath lab or they need thrombolysis. And it's important in late presentation, some of these patients, the old infarct can be picked up by looking at the notching in the lateral leads or mid-precordial leads. If there's a lot of fractionation and notching, that should make you suspect there is an old septal scar in those patients. Second is, if you look at the ST to S ratio, that is, in a person with a chronic left bundle branch block due to conduction system disease, the ST elevation is very minimal compared to the depth of the S wave. In a person with an acute MI, however, the ST elevation is much more in comparison to the S wave depth. So you look at what is known as S to T ratio, and if that is more than 1/4 ST elevation, then it's more likely to be an acute ST elevation MI, and you need to consider as such if this patient has an acute coronary syndrome. Occasionally, you have this kind of bundle branch block-like pattern, but this is not a typical bundle branch block. When you see an effacement of the ST segment in a person with a bundle branch block-like pattern, it should make you suspect a diffuse sodium channel blockade. And the commonest sodium channel blockade that you see in clinical practice is hyperkalemia. Hyperkalemia at very high levels blocks all the sodium channels, and therefore there is a QRS becomes very wide in these patients and presents like a sinoventricular conduction like this patient. And again, when you have these patients with bundle branch block, you need to be extremely careful when you take them for even minor central vein insertion or pulmonary cath insertion, because transient trauma to the existing right bundle can result. This is during a right heart cath in a person with a bundle branch block. The catheter-induced complete CHP can occur. You should be aware of this complication. If you have a person with syncope, and if you have in the same ECG, one showing a left bundle and right bundle, you don't need further testing for this person. Straight away, go ahead with a pacemaker. And this is alternating bundle branch block. The third situation where physicians need to be aware is when you have a person with what looks like a right bundle branch block, but the S waves are absent in 1 and AVL. That should make you suspect he has a bilateral bundle branch block called as masquerading right bundle branch block. These patients are likely to benefit from CRT as much as a pure left bundle branch block. I think I've given just an overview of this. I would like to stop here. By any means, this is not complete. If there are any questions, we'll be happy to handle it at the fit. Thank you so much.
Thank you, sir, for a wonderful talk. I think if there are any questions, I don't see question in the chat box.
You can initiate a discussion.
Yes. I think I should go to
yourself and Shuchit.
Dr. Nasima, this is a very common query that we find an RBB with PR interval of 180 millisecond. And these patients are often refused for any general surgery. In pre-anesthetic checkup, the surgeon will, the anesthetic will say, it is a high risk, get an Holter done. Some say put a temporary pacemaker while doing surgery. So, and patient is entirely asymptomatic. So what your take-home message for these type of patients? Because it's a very common scenario.
Nothing is required. Nothing is required. As I said, if a person is asymptomatic, normal effort tolerance, we can clear them for surgery without any issues.
Second important query, can you tell me which patient of left bundle branch block need further investigation? Asymptomatic 50 years female came with a left bundle branch block. So just tell 4 or 5 points for an audience that these patients, if these are the things, they required further investigation.
Okay. Left bundle branch block initially usually suggests there is some other disease we are missing. At least listen to the patient carefully, look for effort tolerance, look for murmurs, because the commonest reason for that in an asymptomatic person is annular calcification. So either aortic or mitral annular calcium, which starts very as a speck of calcium at the age of 55, 60 in a postmenopausal women, will progress to complete heavy block over 2 decades. So you look for any cause for which will aggravate the calcification. One of the commonest thing is uncontrolled hypertension, hyperuricemia, several other things which can be corrected. So it gives an opportunity to evaluate the patient for aortic stenosis, mitral regurgitation, and of course, if the effort tolerance is limited, you need to think of coronary evaluation. But having said that, the commonest cause in women is uncontrolled hypertension.
Sir, can I ask one question to you?
Sure, please.
Yeah. So how will you evaluate a patient who has a transient LBUB while doing a TMT? Means how will you?
It's a very, very interesting question. Because if you take a ventricle and acutely load the ventricle, you, for example, go and avulse the aortic valve and the ventricle dilates, animals will develop bundle branch block. So there are 2 reasons for bundle branch block happening during exertion. One is long refractory period of the bundle branches, or there is a transient ballooning or dilatation of the ventricle during TMT. So the second cause is more important and malignant. You should suspect a triple vessel disease in those patients. If a patient is symptomatic and he has developed other changes, you should rule out a triple vessel disease. However, the other cause is, of course, asymptomatic progression of an incomplete left bundle branch block, which becomes complete during a sinus tachycardia.
So does the rate is important, or at what rate he develops an LBUV? That may be important in that case.
Yes.
So if he develops at maybe 130 or something, may not be that important as one develops at 80 or 90.
That's right. As you know, the bundle branch block occurs at a higher rate, but resolves at a lower rate. That is, you will develop occurrence of a left bundle branch block at a rate of 150. But it has to wait till the rate comes to 110 before the block resolves because of functional re-entry into the contralateral bundle.
May I have a quick question?
Yes, please.
How do you use a beta blocker or diltiazem in presence of different bundle branch block, second degree and bifascicular block, etc. in these scenarios?
That's a very, very important question. So if you have a person with bundle branch block and normal PR interval in an asymptomatic patient who has got, say, for example, a mild LV dysfunction or hypertension, there is generally no fear of using a beta blocker, because if you actually reduce the sinus rate, the His-Purkinje system will conduct better. On the other hand, if you think the patient has a bundle branch block plus an AV nodal block, which is marked by a little prolongation of the PR interval, then I would be cautious about using a beta blocker in those patients, especially if they had symptoms.
Thank you, sir.
Dr. Narasimhan, there is a question in the chat box. Any comments on Barcelona criteria?
I'm not aware of this.
I'm also not aware of. That's why I just asked you.
Thank you for the question. That helps us to go back and read. Thank you so much.
Rakesh or Shuchit, any other question?
Yeah, one more question. Actually, sir has already mentioned that the role of EP study, when you should do. So how many means we can see a percentage of patients, if we put an empirical pacemaker in a bundle branch block, there is a chance of recurrence of syncope in those patients. Maybe that is around 20 to 25%. So what is your take, sir, on ILR in those patients?
I think ILR is far overrated by the studies. If you really look at it, any ILR, yes, it picks up AFib, it picks up transient AV block, but as a clinician, I'm interested whether the event rates at the end of, suppose you randomize 1,000 patients, have I improved the survival, prevented syncope? Then it becomes very questionable, because the next time the patient comes to you, he may be, ILR will pick up a VF, but the patient is dead. So when you need to have a certain degree, if it's a strong suspicion, it's a traumatic syncope, patient had an abrupt fall, I don't wait for an ILR, I just go ahead and give them a pacemaker.
Thank you, sir.
Thank you. Thank you very much.
Sure, thank you.
Narasimhan, thank you very much. Sure. Soumitra, please take over. Soumitra?
Yes, Dr. Guha. Thank you.
You are not audible, sir. Soumitra is perhaps not audible.
Thank you. So we are going now into a very controversial subject, the ICD, which was fraught with converse birth. And now the controversy is increasing every day with different kind of management going on. So here I invite our chairpersons, Dr. Narasimhan is already there, and Dr. Manatosh Paja. Will have a debate. Just to remind our viewers that 4 years ago, Dr. Shantanu Guha and we published a heart failure position paper on behalf of Cardiological Society of India. And there the role of ICD and CRT, that chapter were hugely contributed by Dr. Narasimhan himself. So he is here with us. So if there is anything changed over the last 4 years from his recommendation, and Dr. Paja, we will discuss that after the debate. So Dr. Paja, please initiate the debate with Dr. Karok and who is that? Dr. Bashab Datto. Yes.
Bashavendra Choudhury.
Okay, thank you very much. Thank you, Goa and Dr. Rai, for inviting this occasion. And I'm very happy to get another chairman with me, Narasimhan, on our friend. So very important subject today, implantation of ICD in primary prevention in India. First thing, should we strictly adhere to the Western guideline? This is very important. You know that Dr. Ovik Karok, Ovik Karok is one of the consultant cardiology in Medical College, and Dr. Basavendra Choudhury also consultant cardiology Medical College. So Dr. Karok will talk again for the motion of this debate, and Dr. Choudhury against the motion. So may I request Dr. Ovik Karok to proceed to start the lectures for motion.
Thank you, sir. Good evening, everyone. Respected chairperson, my teachers, seniors, and my fellow colleagues. The topic of today's debate is implantation of ICD in primary prevention in India, whether we should strictly adhere to the Western guidelines or not. And I would be speaking for the motion. So at the outset, I would like to thank Michael Mirovsky and Martin Mower, the pioneers for the development of ICD. And since the first device that was implanted in February 1980 by Dr. Levi Watkins at Johns Hopkins Hospital, the development in the field of ICD has taken a hugely developing scenario over the last 40 years. Now, ICDs in primary prevention, the ICD has been the mainstay for prevention of sudden cardiac death. The chances of surviving a cardiac arrest in the out-of-hospital setting is very low. The figure is about 4.6 to 8%, which is a very dismal figure in the Western population. And considering the Indian situation, it's going to be even more dismal. Over the last 3 decades, the indications have evolved, and the current treatments of myocardial infarction and heart failure have improved substantially over the last decades. And thus, the patient population at risk of sudden cardiac death may have been altered as well. Consequently, data on high-risk patients after MI and with the heart failure are relatively sparse, and definitely there is scarcity of the Indian data. The rationale behind sudden cardiac arrest prevention is to identify individuals at the highest risk for cardiac arrest and offer an ICD for sudden death prevention, provided they have an anticipated survival time of 1 year with a reasonable functional capacity. However, some have questioned the role of ICD in the contemporary clinical practice, because major point of the controversy regarding primary prevention comes with dilated cardiomyopathy, be it ischemic or non-ischemic, considering the huge burden of the disease. The other indications for primary prevention are basically non-controversial, as I'll touch on later. So the prediction of the degree of benefit from ICD implantation is basically a balance of risk versus benefit. The risk of sudden cardiac death from ventricular arrhythmia vis-a-vis non-sudden death, procedural risk, inappropriate shocks, and device infection. Various validated risk calculators and risk assessment tools are available for aiding in the estimation of each patient's benefit or risk of an ICD. Now, briefly touching over the Western guidelines regarding the primary prevention of sudden cardiac death in ischemic heart disease, LV ejection fraction of 35% or less with an NIHA class of 2 to 3 despite GDMT, or an ejection fraction of less than or equal to 30% with an NIHA class 1 despite GDMT, at least 40 days post-MI and at least 90 days post-revascularization with a meaningful survival of more than 1 year, then an ICD is indicated. In patients with non-sustained VTA due to prior myocardial infarction with an LV ejection fraction of 40% or less and an inducible sustained VT or VF at electrophysiological study, again ICD is recommended. In patients with non-ischemic cardiomyopathy, heart failure with NIHA class 2 to 3 symptoms with an ejection fraction of 35% or less despite a GDMT, an ICD is recommended provided there is a meaningful survival. Now, regarding the patients with bifascicular bundle branch block with unexplained syncope, if the patient is having an ejection fraction of less than or equal to 35%, depending upon the bundle branch block, an ICD or a CRTD is indicated. Now, in patients with cardiac tachyarrhythmia with syncope with the documented VT, definitely ICD becomes an indication. And also ICD is indicated in patients with syncope and previous myocardial infarction who have VT inducible during electrophysiological study. Now, regarding unexplained syncope in patients with high risk of sudden cardiac death, an ICD therapy is recommended to reduce SCD in patients with symptomatic heart failure after more than or equal to 3 months of optimal medical therapy. The ACC American guidelines are in line with the European Society of Cardiology guidelines, both in the ischemic and the non-ischemic cardiomyopathy. Now, briefly touching over the hypertrophic cardiomyopathy, we need to assess the established risk factors, the risk modifiers, and in patients with definite risk factors, becomes an ICD, becomes an indication in these population. Regarding adult congenital heart disease, in patients with adult with repeat TOF with frequent or complex ventricular arrhythmia with unexplained syncope, with at least a moderate ventricular dysfunction or marked hypertrophy, ICD becomes a class 2A indication. In patients with Brugada syndrome, if the patient is having a suspected Brugada without a type 1 ECG, following a pharmacological challenge, if the patient is having an unexplained syncope, and if the patient is an ICD candidate, ICD becomes an indication as a class 1. Regarding long QT, high-risk patients with long QT syndrome with QTC more than 500 milliseconds, females with genotype LQT2 less than 40 years of age and so on, then ICD becomes an indication. Now, what are the arguments against the guidelines? The RCTs conducted many years ago might not be relevant today. Trial population might not relate to real-life patient profiles. Individualization of the therapy needs is important. Medical therapies for HFrEF have evolved and hence might have lessened the survival benefit of ICDs. Definitely the Danish study and the cost of the therapy is also important in the Indian perspective. So let us now evaluate these arguments closely on the merit. Wait, before going to ICD, why not medical therapy? So the various sudden cardiac death prevention trials with antiarrhythmic agents like CAST, CHF stats, SWORD, and so on, with multiple antiarrhythmic agents have effectively shown that some of the trials are negative trials, and basically they have made the antiarrhythmics wanted for murder. So here comes the role of the hero of our talk today, the device that delivers shock, that is ICD. So there's a huge body of evidence supporting ICD, both old and new. Older pivotal trials establish the efficacy of ICD, not only in secondary prevention, but equally so in primary prevention. The MADID-2 trial, the SERI-HEF trial, which has shown significant reduction in the mortality with survival benefit. Even in the non-ischemic cardiomyopathy with definite trial, there is a significant improvement in the survival. The recent publications have also been in favor of ICD implantation for primary prevention. The UCERT ICD trial, which was published in 2020 in the European Heart Journal, showed that in contemporary ischemic cardiomyopathy or dilated cardiomyopathy patients with an ejection fraction of less than or equal to 35% with a narrow QRS, effectively ruling out CRT in these patients, a primary prophylactic ICD treatment was associated with a 27% lower mortality after adjustment, though there appeared to be lesser survival advantage in older patients or diabetics. But if we look into the pooled analysis from 5 different RCTs published in 2015, the benefit of ICD even remained with the elder age group, though it was slightly attenuated. Thereby, age alone cannot be a reason to withhold ICD therapy. So the key findings from the newer studies is basically HFrEF patients receiving ICD have similar survival benefit to patients who received an ICD in the MADID 2 SCD HEF trials. Medicare beneficiaries with a LV ejection fraction of 30 to 35% hospitalized for heart failure had better 3-year survival with an ICD than without ICD. And the survival benefit was across a diversified group of patients in various studies, including women, racial minorities, and patients with multiple comorbidities. So most importantly, these observational studies sheds light on the role of primary prevention ICDs in patients not well represented in the randomized control trials also. Now, if we look into the SWEDE HF trial, ICD use was associated with a reduction in the all-cause mortality risk at 1 year and 5 years. Well, in the CSI consensus statement, the implantation of the ICD was relaxed to up to 2 years survival. So, in this publication, it was shown that the all-cause mortality reduction benefit was seen as early as 1 year itself. And in this study, it was also identified that there was underuse of the ICD for primary prevention purposes, and they recommended to support the current guidelines and better implementation of ICD in the clinical practice. But what about the Danish study? It's important to understand the nuances of the study to evaluate its implication. The Danish trial allowed use of CRT in both the arms of the trial in the tune of about 58%, and the trial required that the patients had an elevated NT-proBNP level, thereby placing them at higher risk of advanced heart failure death rather than sudden cardiac death itself. A secondary analysis of the Danish trial showed a significant reduction in mortality with an ICD in patients less than or equal to 70 years of age. So we look into the meta-analysis of 4 randomized clinical trials, including the Danish trial published in 2017 in JAMA Cardiology. It showed a 25% reduction in all-cause mortality by a primary prevention ICD implantation. These findings support the professional guidelines. ICD is still relevant despite the recent advancements in HFrEF managements. Undoubtedly, the management of HFrEF have improved drastically in the recent years. However, there is no strong evidence that this reduces the potential benefit of ICDs, and because majority of the patients with HFrEF are not candidates for CRT because they don't match the criteria for CRT implantation, and also the usage of neurohumoral antagonists might not be in the same tune as in the trial settings. The Trivandrum Heart Failure Registry showed a very dismal finding that 3 out of every 5 patients had died during 5 years of follow-up, with a median survival of approximately only 3 years. So thereby proving the fact that despite the development in the armamentarium of HFrEF patients, there is significant mortality of these patients. So then what to do after GDMT then? Is cost an issue against an ICD, or should we actually follow the Danish legacy? Because the two statements are actually contradictory. Because if we have to follow the Danish study, then we need to implant CRT to negate the beneficial effect of an ICD. But in that situation, we need to increase the implantation of CRT, which again is a costly affair. And moreover, a lot of patients do not match the criteria for CRT, which again becomes an issue in our management of HFrEF patients. So this a survey was conducted by the Indian Society of Electrocardiology and Indian Heart Rhythm Society, a survey of cardiac implantable electronic device implantation in India, which showed that single chamber ICD was most frequently used for prevention of sudden cardiac death from ventricular tachyarrhythmias. Primary prophylaxis use was seen in the tune of 52.5%, and the most common etiology of ICD use was coronary artery disease in 58.5%, followed by idiopathic DCM with 31.8%. And the indication for ICD implantation was almost equal for primary and secondary prevention. So the Western guidelines not followed in practice in India due to high cost basically is a misconception. So before I conclude my talk, the ICD can be replaced by a pacing system. It may be removed or abandoned at the time of ICD generator, end of life or service in patients with life-threatening comorbidities at the request of the patient, or when an ICD is unlikely to increase the life expectancy. So in conclusion, it can be said that ICDs have stood the test of time, and thereby whether we should strictly adhere to the Western guidelines is a big yes for me. Thank you. I rest my case.
Thank you very much, Dr. Karok. Then excellent talk for the motions. Next talk, Dr. Basudhara Chaudhary. He'll talk for 12 minutes for against the motions? Dr. Chaudhary, please. Dr. Chaudhary?
Yeah.
Unmute.
Yes. Am I audible, sir?
Yes, audible, and your slide is visible.
Yeah. So, big thanks to Dr. Shantanu Go, sir, for this opportunity for enabling us to discuss such an important topic. So, Dr. Karak, my friend, has very nicely put his case forward regarding why we should support the Western guidelines. At the onset, I would like to make some things clear. So I am speaking against the motion that we should not strictly adhere to the Western guidelines for primary prevention using an ICD implantation. The word strictly adhere, I would like to focus on. The Western guidelines have been made with good intention so that a large volume of patients can be given the latest therapy available so that we can prolong survival as well as decrease morbidity. However, actually, where do the guidelines fall short? So the same therapy cannot be a tailor-made one for each and every patient. So always there is though the guidelines are here to support us, there is always a scope to individualize on a patient-to-patient basis and look for finer points where we can adjust and go for a tailor-made therapy instead of just strictly following our guidelines for its sake. So the first problem with the guidelines are that we all know that most sudden cardiac deaths are occur in our society in patients who actually don't have any history of cardiovascular disease or who have a relatively preserved ejection fraction in their last medical records. The latest example which comes to our mind is that of Christian Eriksen, the Danish footballer who just collapsed while playing in the recently conducted Euros 2020. He was a top player in the top European clubs for almost a decade now, and obviously there were no obvious abnormality in his cardiological checkups which could not have gone unforeseen. So actually there is no tool or guidelines or recommendation present to pick up those patients by screening programs or tools from our society or from the general population who can actually benefit by preventing a sudden cardiac death or a sudden cardiac arrest. And no recommendation for ICD for primary prevention for subset of patients is still there. So also moving on, only a minority of patients who receive ICD therapy actually receive an appropriate shock. It is only around 2.6% in primary prevention cases and 7.4% in secondary prevention at the end of 30 months. And weighted lifespan gain at 3 years with an ICD is only 1.5 months for primary prevention. And also, as Dr. Karak has also explained that with the advancement in the pharmacological heart failure and reperfusion therapies, the annual sudden death rates have also declined, which further decreases the benefit provided by costly therapy like ICD. And also, as years have gone by, the amount of proportion of unresponsive patients have increased, as I will touch upon in the later slides. And also, by dividing patients into ischemic and non-ischemic groups, actually large myriad group of etiologies and heterogeneous disease conditions are actually neglected, and detailed evaluation and treatment of those systemic conditions are often missed. Next, another point against the guidelines is the over-reliance on echocardiography. Though it is the very important tool, no doubt, for a routine cardiological checkup and assessment. Geometric assumptions from 2D measurements often fail to give the actual volumetric assessment of the ventricles and their function. They are influenced by the loading conditions, often not reproducible and accurate, especially in patients with wall motion abnormalities. And no clue regarding arrhythmias are obtained. And also in patients with low EF, often comorbidities, especially CKD and end-stage renal disease, which have higher SCD risk and low benefit after ICD implantation, these things are not included in the guidelines. Only the life expectancy of more than 1 year, this thing has been included over the years. With every therapy, besides the possible benefits, there are the risks associated with it. So let us look into the risk associated with ICD therapy. So the acute conditions during the implantation procedure, which can complicate the procedure, we all know some of them are trivial and can be managed easily. However, some of the conditions may be life-threatening, such as pulmonary embolism, pneumothorax, cardiac perforation, and complications related to defibrillated threshold testing, resulting in post-shock pulsar electrical activity, embolism from conversion of AF, and so on. And infection, though not that common, are on the rise as more and more procedures are being performed. And we must not forget, because infection of ICD often requires complete extraction of the system, which itself can be very dangerous and a costly affair, and you even have a high morbidity and mortality. Next comes the issue of inappropriate shocks. So even after ICD implantation, we cannot just rest and be happy and tell the patient and their relatives that we have given the device and it will take care of the problems. Up to 5 to 15% of patients can receive an inappropriate shock, and for some reason, mortality rate is almost doubled in those patients who receive inappropriate shocks. And often in the case of with primary prevention, as the patient has not yet suffered a sustained ventricular tachycardia, so the issue with VT threshold is always there, and often sinus tachycardia with aberrancy or supraventricular tachycardia, or often AF are taken as ventricular arrhythmia by the device, and the patient go on receiving shocks. And inappropriate ICD shocks themselves can further give rise to further arrhythmias. And the psychological effects of incessant shocks, recurrent shocks, can be quite disabling. And up to 40% of patients who receive ICD therapies go on to develop psychological issues like anxiety, depression, or PTSD. And lead failures and recalls have been well reported in Western literature. I will not go into the details, but these things are definitely should be kept in mind before we go on prescribing ICD and implant ICD for a patient. So some of the authors have tried to devise some tools or some schemes which can predict which patient will have a less chance of shock and less chance of death, which patients will have a less chance of shock but high chance of death, which patients will have a high chance of both shock and death, and which patients will have a high chance of shock and will yet survive. So some of the factors like ischemic heart failure pathogenesis, atrial fibrillation, diabetes mellitus, renal insufficiency, and in higher NYHA class has been associated, which can lead to death even after shock or death without shock. And these things can be, we can put the patients either in this A, B, C, D, 4 subgroups and discuss with the patient and party and what actually they can expect after ICD implantation, what benefit they can expect, and what can be the course in the near future. Next comes the cost versus benefit ratio. Even the advanced countries like the US and the European based cost benefit analysis have given mixed results whether ICD should be routinely used in primary prevention. So the key is to implant devices in moderate risk patients who would more likely to use the ICD, get the benefit of ICD, but are less likely to experience death due to high risk conditions. And as in a country like India, which in 2016 itself had an estimated heart failure population of 8 to 10 million, and which is always on the rise, cost benefit analysis is certainly should be taken into account before we say that ICDs can be used for primary prevention for all the heart failure patients, because the patients who will qualify for ICD implantation is huge. and neither all the patients nor the government is ready, as we all know, to implement this sort of rule or strategy. So now we will look into the details of some of the recent studies which have looked into the declining clinical benefit of ICD in heart failure patients. So if we look at the older studies which were done for primary prevention, ICD versus OMT, like the MEDIT and the MUST, NSVT and VTVF inducibility were a definite criteria for enrollment. However, later on these things have been neglected, and the recent guidelines, as Dr. Karak has shown, does not include the VTVF inducibility or the NSVT criteria. Only the ejection fraction is being highlighted upon. I think with that, both the number of unresponsive patients and the number needed to treat is actually increasing. So another important thing is that the advancement in the heart failure therapy, even if you don't consider ARNI, the proportion of patients receiving beta blocker, ACE, ARB, MRA, and even CRT therapy have been actually on the rise, as has been shown in this slide. In the latest trial with for primary prevention in non-ischemic etiology of heart failure, the numbers are actually quite high. 92% of patients receive beta blocker and 97% of patients receiving ARB RAS blockade. So if we look at the outcome data, so definitely if we see that the total mortality, that the annualized event rate in the control patients itself is on a decreasing trend. Also, the hazard ratio is actually increasing, suggestive of that the benefit given by ICD for total mortality is actually on the decline, whereas the number needed to treat at 3 years and 5 years are increasing. That means in order to get benefit, we have to provide with ICD to more number of patients. And after the results of the Danish trial, which showed no significant mortality benefit of ICD therapy in non-ischemic cardiomyopathy, the debate has again arisen. So if we look at this is the first sort of study which has looked into the primary prevention of STD, included 7 trials, major trials. The baseline STD risk, the baseline risk of total mortality have been on the decline, whereas the patients unresponsive to ICD and the clinical benefit of ICD, the number needed to treat has been increasing. This slide also gives similar sort of information. So 2 factors, the progressive decline in the baseline risk of STD and total mortality, and the progressive increase in the percentage of patients unresponsive to ICD, actually combined to actually decrease the benefit of ICD in primary prevention. Improper ICD functioning resulting from ventricular undersensing, unsuccessful final internal stop, lead failures are also there, and non-cardiogenic causes of death have also been arisen, as patients with HFrEF are all often associated with important comorbidity. So another recent studies, including quite a large number of patients, ischemic and non-ischemic, have shown that in diabetic patients and in older patients above 70 years, the ICD survival benefit is actually less. And after adjustment with mortality predictors like age, LVEF, NYHA class, creatinine, and COPD, the survival benefit provided by ICD has decreased from a number of 32% to 27%. So what can we do? Definitely some risk models we can follow, like the Seattle proportional risk model, which applied on the MEDIT-2 trial, showed that the patient on the lower quartile definitely did not get the benefit, mortality benefit from ICD therapy. So Bilchik and Casey et al. In JAC 2017 actually published a very beautiful article which showed how we can use the Seattle heart failure model to assess the mortality risk, as well as the Seattle proportional risk model to assess the SCD risk. So the patients who are most likely to benefit from ICD are the patients with low SHFM and high SPRM score. Also in this study, late gadolinium enhancement in the cardiac MR, which can very effectively predict ventricular fibrosis, have a significantly higher risk for VTVF compared to those without the fibrosis. This can be used to further risk stratify the patient so that best possible therapy can be given. And also another important thing is the patient and the party should be discussed with the should be shared decision making should be done. We just should not give our opinion and impose it on the patients. So apart from the no doubt the Western things attract us, and the Western guidelines are quite attractive, and we often fall for it. Actually, the homemade recipes and homemade tools and strategies are often the more effective one. So as stated by the CSI in 2018 in the CSI position statement, we can modify the Western guidelines and use to our benefit. So ischemic cardiomyopathy with less than EF less than 35%, MI more than 40 days, OMT more than 3 months, and life expectancy more than 1 year. Then we can look for the functional status. And if they are not a candidate for assist device, then we can again stratify the patient, including the high risk markers for SCD like documented NSVT, inducible VT during EPS, and if they are present, we can safely prescribe an ICD. Same for the non-ischemic DCM with EF less than 35% after OMT for 3 months. If they have a survival, the expected survival at least 1 year, and they fall in the NYHA 1, 2, or 3 class, then we can look for delayed enhancement on cardiac MR showing mid-myocardial scarring, or non-invasive markers of electrical instability like fractionated QRS, LVDB, or complete heart block, or T-wave inversions, or QT prolongation. Or if there is a family history of sudden cardiac death, then we can go for ICD therapy instead of just strictly adhering to the Western guidelines. So always there are options in front of us. There is a main street in the form of the Western guidelines. There are roads less traveled. So often we have to make our own strategies. And no doubt the data in our setup, Indian setup, is less. And the strategies for HCM in the Western guidelines is quite detailed, and risk stratification is present. But as far as the ischemic and cardiomyopathy and the non-ischemic DCM goes, which actually from the bulk of the patients of HFrEF who qualify for ICD therapy, we often have to risk stratify and modify the Western guidelines to our own advantage. Thank you.
Okay, Dr. Chaudhary, we have got 6 minutes, and Dr. Karo is requested to talk 3 minutes in his favor.
One of those, there is no rebuttal.
Oh, okay.
No rebuttal.
Okay.
You give your comment. Dr. Narasimhan is there. Let him give
yes,
his comment.
Dr. Narasimhan, please give an advice and to how to stop their battle.
I think both of them have presented very well their own perspectives, and it's important to look at both sides of the coin. But I think what has happened is with these guidelines, physicians have lost their capacity to individualize the treatment. And the treatment is a moving target. For example, if you take streptomycin for TB is gone, chloramphenicol for typhoid is gone, within 5 years, newer drugs have replaced. Similarly, the heart failure mortality has come down significantly with tremendous advantages in heart failure therapy. So it is a moving target, and you need to risk stratify a patient who is likely to die more due to arrhythmia than to heart failure. So transiently improving the survival for 6 months, but ultimately within 2-3 months dying doesn't help. So these things need individualization. In a country where the resources are constrained, I don't think we can follow the Western guidelines as such. We need to take the message and apply it to our patients.
Okay. So my question that, Dr. Karo, that you have to wait, and all the literature also mentions the optimum medical therapy must be given at least 3 to 6 months in spite of ventricular irregular beat. So what your opinion in that point of view? Optimum medical therapy.
Definitely optimal medical therapy with has to be given, and in all the guidelines also it has been recommended that at least 3 months of optimal medical therapy is needed before thinking about or suggesting an ICD in the patients, and it should include beta blockers, ACE inhibitor, ARB, or ARNI nowadays, the mineralocorticoid receptor antagonists, and definitely after the reaching the guideline directed dosage of the individual drugs for at least more than 3 months, and after reassessment of the clinical status and the echocardiographic evaluation to look into the ejection fraction, whether it is improving or not. After that, we should decide regarding advising an ICD as recommended by the guidelines.
There is a question came in the chat box.
Okay.
Why 40 days is selected for putting an ICD in post-MI patient? Why is it 40 days? By Dr. Jamil Abdul. Dr. Narasimhan, would you like to take this and just have a quick answer?
Yeah, the reason for that was they believed that the LV function, this applies only for secondary prevention. Primary prevention ICDs. So if a person had a VT after 48 hours after an MI, sustained monomorphic VT, then he merits a device. Whereas if a person has nothing, but the EF is 30%, there is a good chance the EF is likely to improve with appropriate medical therapy in about 6 weeks' time. And the risk of sudden death comes down once the LV remodels. That is the reason for taking those 6 weeks cut off.
Beautifully explained. Beautifully explained.
Okay, Dr. Narasimhan, my question that is in cases of the ischemic cardiomyopathy, we have to correct whether the 30% to 40% ejection fraction, we have to correct the revasculation therapy, particularly either angioplasty or CABG. Otherwise, this IC not be helpful. For your comment.
Very true.
Yeah.
Very true. If residual ischemia needs to be corrected, medications need to be optimized, these things significantly bring down the risk of sudden death. So when we discharge a patient, his BNP is still high, the risk continues to be high. The QT is long, the risk continues to be high. He has a sinus tachycardia, the risk continues to be high. So if there are simple clinical markers we can use and try to optimize, and of course all the ischemia, residual ischemia needs to be corrected.
In cases of DCM, non-ischemic cardiomyopathy, that cases if you do the particular the ICD.
Yes. Again, probably one of the speakers can take up. We have understood that the risk of sudden death varies from the genotypes.
Yeah.
So even if there is minimal scar, there are certain DCMs which are more arrhythmogenic, like laminaceae or some of the newer mutations which are desmoplakin. Some of these are predominantly arrhythmogenic. Whereas some things like titin mutation or dystrophin mutation, they have a very low risk of sudden cardiac death. So we are understanding this entity better and better over time.
Pavitra, any other question in the chat box? Dr. Rai?
No, sir. You can conclude, sir, if you like.
Okay.
Yeah, there are several sessions. You conclude, please. Monothos, conclude.
Okay, thank you very much. Both the speakers done a good job. And what are the indication? What are the contraindication? They have already shown the particularly Dr. Chaudhary mentioned the contraindication, complication, and the effectiveness. The contraindication is very high because infection, leak, and inappropriate shock, rightly mentioning. But appropriate cases, particularly hypertrophic cardiomyopathy, one of the important cause little light. We have done the apical cardiomyopathy. You have published in the Indian Heart Journal. Out of 40 cases until now, their mortality is very high. Only one person had died because cardiac arrhythmia, and that is even in spite of the ICD. So therefore, the appropriate case selection very needed by clinical history and ejection fraction, life expectancy associated with COPD or diabetes, that should be considered. Thank you very much. Both the speakers done very good job and upgrade our knowledge, and good comment from Dr. Narasimhan, and well done. Thank you, Narasimhan.
Thank you,
Thank you,
sir.
thank you, sir.
To the chairpersons and the speakers, I simply understand one thing. We are very enthusiastic about putting an ICD on, and then we are very less enthusiastic to get a feedback from the patient, sir, I have got a shock. So we pray to God and amiodarone so that the patient does not share his shock with us. So that's where I finish. The next 40 minutes, we shall have a bonanza of ECGs from Dr. Narasimhan. I request Dr. Munnadas and Dr. Devobroto Bera to introduce Dr. Narasimhan's session, please.
Yes, sir. Good evening.
Very, very basic. So this is a patient who came with an vague chest discomfort and sweating. And then because hospital was nearby, he walked in within the first half an hour after the onset of discomfort. So the choices given, do we have a choice for MCQ or audience poll? If not, I'll just go ahead. So this is a very important ECG sign where Deventer described this as an acute hyperkalemic change, but restricted to 2-3 leads. Please remember, when there is an acute ischemia and the vessel is occluded, there is a lot of acidosis there and the potassium elutes from the cell. If that happens within a localized area, you will find something like hyperkalemia there. Typically a tall peaked symmetrical T wave and a very minor ST depression, and the effacement of the ST segment. You see the QRS merges into the T wave. All these things suggest that there is a regional ischemia which is very acute. Even before the infarction happens, this ECG changes are present. And the importance of recognizing this is, if you revascularize this patient, quite likely you can abort an infarct. And the treatment here is immediately give a nitrate if the patient is a smoker, recheck the ECG and get the cath lab activated. Very rarely you may have resolution of these changes if there is a resolving thrombus, but 9 out of 10 you need to take them to the cath lab for early revascularization. So Deventer's group from Valence, Netherlands, described this as an upsloping ST depression in precordial leads, peaked anterior T waves in the mid precordial leads V2 to V6, with the ascending limb of the T wave starting below the baseline, the ascending limb of the T wave starting below the baseline, and subtle ST elevation in AVR. This is a typical Deventer T wave, and the patient is acutely ischemic. You need to rush him with anti-ischemic therapy and rush him to the cath lab. This is a patient with orthopnea, severe mitral regurgitation. This is one thing which I would like you to remember. Of course, here it's very dramatic, an ST depression. But if you look at the R wave amplitude in V2, it's much taller and the T wave is upright. This should make us suspect that you're dealing with a posterior wall infarction. And these patients, when they develop mitral regurgitation, it's an urgent indication to revascularize because that papillary muscle is ischemic, and you may be able to abort an infarct and abolish the mitral regurgitation here. So this is a sign when you see a tall R in V1 and V2 accompanied by a tall T wave in the upright T wave, it should make you suspect you're dealing with a posterior myocardial infarction. This is inferior wall infarction with posterior wall involvement, and mitral regurgitation 9 out of 10 will get abolished or at least get minimized once you revascularize this territory. So how do you recognize ST segment depression, horizontal or downsloping like this case? Very prominent R wave in lead V1 or V2. RS ratio is more than 1. RS ratio is more than 1 in V2. Prominent upright T wave as was seen in this patient, and combination of horizontal ST depression with upright T wave. Usually this happens in the company of an inferior wall or a lateral wall MI. And when you're unsure, you may use V7 and V8 in the posterior location to document. Now, this patient presented to us about a year ago with rapid palpitation, recurrent atrial fibrillation, and you can see RR interval with ST changes. He was given loaded with drugs, heparin, and then given a beta blocker, and the rate came down. I would like to draw attention to the same fact. The STs are normal in V1, but very markedly depressed in V2, and the T wave is upright with a prominent upright QRS in V2. The next day, you find a completed dorsal infarction here in the same patient. The reason why this is important is to understand left atrial circumflex artery is a branch of circumflex, and that supplies the left atrium. When they become acutely ischemic, you can have atrial fibrillation as the presenting manifestation. Now, all the attention in this patient was devoted to atrial fibrillation. Someone forgot to look at the prominent STT changes, and this patient should have been rushed to the cath lab rather than treating him with more and more amiodarone in this patient. Unfortunately, it was a missed opportunity to treat. He had a completely occluded circumflex, which was opened much later. So when you have doubt what you're dealing with is an infarct or just an ST segment depression, ACS versus an infarct, you can just take an have the leads on V7, V8, and V9, which is in the interscapular line, posterior dorsal interscapular line, and that will show an ST elevation. And these patients, when revascularized, either with thrombolysis or with acute PCI, you will have the same benefit as patients where this diagnosis was missed. Again, to physicians, the commonest misdiagnosis of myocardial infarction is dorsal wall myocardial infarction. The clues are prominent R wave in V2 in the presence of an upright T wave in V2. This is a 55-year-old person, presents with nausea and chest discomfort. So the diagnosis entertained, was it acute pancreatitis, pericarditis, acute coronary syndrome, or pulmonary embolism? So again, we would like to draw attention to this simple sign, which was described way back by Shamrock, which is called horizontality of ST segment. If any of the leads hug the baseline, normally the ST segment is supposed to be either smooth upstroke into the T wave, it merges, whereas if it hugs the baseline and it's very horizontal with a sharp uptake of T wave, that should make you suspect that this patient has an acute coronary syndrome. The second clue is a sudden diminution of the R wave from V2 to V3. The total QRS voltage suddenly comes down. All the company it keeps suggests that this patient has an acute coronary syndrome and actually had a tight LAD lesion. This is what I mentioned. In a normal patient, the ST segment smoothly merges into the upstroke of the T wave. Whereas in patients who are having an ischemia, there will be a sharp upstroke and a very horizontal STT angle. Now, please remember, this doesn't mean always it's acute coronary occlusion. Severe subendocardial ischemia in a hypertrophied ventricle, severe subendocardial ischemia in a person with HCM can have all these manifestations. It's a physiological equivalent of a severe subendocardial ischemia. the same patient, left untreated, will lose all the R waves, and at the end of it, you will be left with a large myocardial infarction if it is not treated. Again, this is a patient with a left bundle branch block, presents with chest tightness for a brief duration, left bundle branch block morphology, which limits the diagnostic capability, but ST segment elevation that is concordant to the lead where the QRS is also upright should make you suspect that this patient has a lateral wall myocardial infarction, and he should be given either a lytic therapy or referred to a cath lab where the vessels could be open. So whenever you have an ST segment in a left bundle branch block with an upright QRS complex, QRS is upright and the ST segment is also upright. Patient who didn't have much of symptom, he came for a routine evaluation. However, he came for evaluation because 3 days prior, he had a mild chest discomfort while he was traveling. And the relatives brought him for a detailed evaluation. He's a diabetic on metformin and was on aspirin. He came for a master health checkup, and then would you do a stress testing or admit and observe, or would you refer him to the cath lab, or what will you do? Now, the reason why this ECG was put in was, again, when you see this kind of a T wave, symmetrical T wave inversion, which is a biphasic T wave inversion, in any of the precordial leads, this indicates the patient has a critical LAD lesion, and you should not do a stress testing on these patients. Not only that, you don't need further testing. This particular sign of a biphasic T wave indicates a large area of underlying hibernating myocardium, which means if you revascularize the patient, the LV function will completely normalize. So this is the importance of clinical observation. A simple electrocardiographic sign tells you a large area of myocardium is at risk, it is ischemic, and the muscle is completely viable, and you need to immediately revascularize. This sign is described by Hein-Wellens, and it's called Wellens sign. Two morphologies are described in V2 to V3, either a symmetrical T wave inversion arrowhead or a biphasic like this, up and down. If you see this, please do not put them through a stress test. Refer them for an angiography and revascularization. So Wellens syndrome, the description is a deeply inverted or a biphasic T wave in lead V2 and V3. It's highly specific for a stenosis of critical stenosis of LAD. Generally, when the ECG is taken, patients are free of angina. They don't have chest pain. This has happened 2-3 days prior. And they are at high risk of extensive anterior wall MI, and mortality risk is high. Please avoid stress testing. There is a high risk of MI or cardiac arrest during stress testing in these patients. Now, this is again a patient who presented to our casualty with chest discomfort. The ECG looks apparently normal, but there is a minimal ST elevation in lead 3 and AVF. Now, whenever you have this kind of a minimal ST elevation, you are left guessing whether it's a true myocardial infarction or whether it's non-specific. So whenever you have a suspected myocardial infarction of the inferior wall and you are unsure, look at lead AVL. If AVL shows a horizontal ST segment or ST segment depression, this indicates this is real. This is not non-specific. So AVL minor ST depression in the presence of ST elevation in inferior wall confirms that this is an acute myocardial infarction, and you don't need further testing. So whenever there is an ST elevation accompanied by, you need to compare this against the TP segment, there is an ST depression. You need to take them to the cath lab. This was originally described by Birnbaum and Skarlowski. Whenever there is a doubt of an inferior wall infarction, they suggest look at AVL. So ST depression in AVL is a very sensitive marker for inferior wall infarction in the acute stages. Now, whenever you have patients coming to casualty with bradycardia or even complete AV block, this is one P wave, there is a AV conduction disturbance in this patient. And if this patient has a tall peaked T wave, the diagnosis is hyperkalemia. And the reason why this ECG is important is suppose you're in a remote place and your lab is going to give you a result in 3 hours time. Even before you get the potassium results, you need to start acting, and this patient would immediately respond if you start anti-hyperkalemic therapy. Immediate calcium gluconate, flush with saline, then in the same line sodium bicarbonate, and if possible give Kxalate. For the bradycardia, you need to start treating appropriately. This is you can completely save the patient if you start treating the patient even before you get the lab report. This signs can progress to asystole. If you fail to treat this, within hours they go on to a flat line, and even putting a temporary pacemaker may not help this unless you correct the hyperkalemia and acidosis in these patients. So predominantly at lower levels of high potassium, that is potassium in the range of 5.5 and 6, you get predominant T wave changes like peak T wave. As the potassium climbs, you start seeing P wave flattening, and P waves sometimes